Yes, sir, you are live now, sir. Sir, you are live now. Vikram, sir, please unmute. Yeah, please start, sir.
We'll start in half a minute, or is it 3:30?
I think 1 minute is still there.
Yes, we'll start at 3:30 sharp. Or shall we start?
So 3:30.
Okay. So respected IMA Maharashtra State Vice President Dr. Dinesh Thakre sir, IMA Amravati President Dr. Rohankar sir, Secretary Dr. Sabu sir, executive members, speakers and delegates, good afternoon to all of you. On behalf of IMA Amravati, I welcome you all for the second day of AGNIPANKH 2020 IMA Amravati's web conference. Yesterday we had a great academic session in which 8 speakers spoke on various common topics and gave valuable information which will be useful to all of us in our day-to-day practice. I congratulate all the speakers who spoke yesterday. I also congratulate Dr. Vikram Wankhede for a flawless anchoring of yesterday's event. Today also we have 7 to 8 reputed speakers. I'm happy to inform to all of you that this program is being recorded and will be available on IMA Amravati's YouTube channel for coming years to come. So all the speakers can publish these recordings for the benefit of their colleagues and patients. I'm glad to inform that MMC has granted 2 credit points to this web conference. However, it is important to mark your presence by filling the Google form to get these credit points. You can find the link of the form below the YouTube screen and also on the WhatsApp group of AGNIPANKH 2020. I want to inform that only those who have registered for AGNIPANKH 2020 are eligible to get the credit points. So today our Master of Ceremony is Dr. Anuradha Toti Madam. So over to you, Madam. Madam, please unmute yourself.
Thank you so much, Vikram sir. A bright and sunny afternoon to one and all. And on behalf of Amravati IMA, I welcome each and every one present here. Our respected President, IMA President Rohankar sir, of all the office bearers, ADC, Dr. Vikram Deshmukh sir, the speakers, the galaxy of speakers we have today, and the delegates and the viewers. I welcome you all to this wonderful webcon, which we are going to start right now. And as I have already mentioned, we have a galaxy of speakers from different specialties of our medical field. And they are Dr. Ashish Ganjare with the topic Recent Trends in Treatment of COVID-19, Dr. Lalit Raut with the topic Crisis in Sickle Cell Patients, Dr. Saili Jahagirdar with the topic PPH Bundle, Dr. Amit Kavimandan with the topic Non-Alcoholic Fatty Liver Disease, Dr. Shripad Jahagirdar with the topic Picky Eaters, What Parents Can Do, Dr. Kshitij Patil with the topic Aesthetic Rhinoplasty, and Dr. Dinesh Thakre with the topic Death Certificate in OPD Setup. So stay tuned and we begin now. So may I request the first speaker, Dr. Ashish Ganjare, sir. A short introduction of Dr. Ashish Ganjare. He has done his MD Anesthesia from Tata Memorial Hospital, Mumbai. He has done his fellowship from PD Hinduja National Hospital and Tata Memorial Hospital, Parel, Mumbai. He has worked as a consultant at Critical Care SIMS, Nagpur and Sunflower Hospital, Nagpur. At present, he is a consultant at Critical Care of Aureus Institute of Medical Sciences, Nagpur. So please welcome the director and founder member of Aureus Institute of Medical Sciences. And his topic is Recent Trends in Treatment of COVID-19. Over to you, Ashish Ganjare, sir.
Now I will going to start my topic. Yeah, everyone is able to hear me. Hello.
Yes, sir. We are able to hear you and we
Yeah,
can see
yeah,
the presentation,
yeah,
sir.
yeah. Now today I'm going to talk on this recent trends in transmission, diagnosis, and prevention, and imaging of this COVID-19. If you see that what is the basic background behind this C19 is this coronavirus is initially identified as a pneumonia virus in and it was named as a SARS-CoV by WHO on 12 Jan 2020. It's basically originated from the local seafood market in Wuhan city, China. And what they found, the most common infected patient, what their clinical symptom is around more than 60 to 70%, they reported with the dry cough, and around 30 to 35% presented with a wet cough. And this cough is a major transmission of this COVID-19 infection. If you see the clinical symptoms, as this is a zoonotic origin virus, what are the primary symptoms? Mostly the fever, fatigue, dry cough, sore throat, sputum production, muscle pain, respiratory problems. These are the clinical symptoms. On the lab base, what they found is the around 70 to 80% presented with a lymphopenia, and around 30 to 35% presented with the leukopenia. If you follow this lymphopenia, like if you look after every time those patient while managing, alter neutrophil lymphocyte ratio. Hello.
Yes, Ashish, sir. We can
Hello.
hear you, sir.
Yeah. Yeah.
Ashish, sir, we can hear you.
Yeah, sorry, yes, I'm not able to see the this side. Yeah. So what on clinical basis, if you see this lymphopenia symptoms, practically the patient presented those who are in a very bad situation or in a clinically deteriorated, severely hypoxemic. If you monitor this neutrophil lymphocyte ratio, you will definitely find out those patients who are critically ill, they will have the significant lymphopenia. And as the patient clinically improve, this lymphocyte count also improved very well. Now, what is the current situation? If you in a current situation is around of this coronavirus infection, the present scenario from that old scenario from January 10 to 13th March 2020, there were around 7 lakh 52,000 reported COVID-19 cases. Out of those, around 36,000 deaths noted around the world. And that time, if you see on the world meter of corona, there's a mortality rate was very high, around 15%. And this, as this mortality was definitely significant, but as the treatment procedure was aggravated, the mortality rates were reduced significantly. And the current mortality rate was around 10% among the positive. But this, if you see again now, is from today's point of view, I will give the exact data of how many patients got get infected. The if the from the today's, sorry, I'm sorry for the interruption. I think just because of some calls, I'm not able to run the slide. Hello. Sorry, I'm not just able to run a slide. Give me 1 minute. You are able to see this slide, current situation in India? You all?
No, sir, we cannot
Hello?
see the slide, sir.
I'm also not able. Sorry, I don't know what is happening. They're unable to see the slides.
Sir, just stop the screen sharing and on it once again, sir.
No, sir. Hello. Hello.
Yeah, technical snags do come, and
Sir.
I request Ashish sir to go ahead without the presentation also.
Yeah.
Even that
Okay.
would be fine.
Just okay. Okay. Yeah. Uh, so what is like this current situation in the world? If you see, there were around 66 crores, around 86,000, 80 lakhs patients positive from today, and around death is around 15 lakh, around 34,000 for today. And if you see the current situation in India for today is around 96 lakhs 44,000 patients were positive. Out of those, around 140, around 1 lakh 40,000 has got a mortality due to corona, and recovered around 91 lakhs patient recovered. If you see the basic structure of C19, this COVID-19 looks similar to SARS-CoV that originated from the bats. There were few samples which revealed that this spike protein content of this SARS-CoV-2 is not a bat beta coronavirus, or not from the pangolin of beta coronavirus. And no animal virus look the same as COVID-2. Besides, again, there is some mutation in this spikes protein which makes COVID-2 binds with the human AC2 inhibitor. Again, the progenitors of this COVID-2 jump to humans without being detected, and again it was transmitted rapidly from human to human. That's why the similar from COVID-1 to COVID-2, this acquired this receptor binding protein domain, plays a role in a mutation during transmission into the cell, where the study revealed that this COVID-2 is not purposefully modified virus. If you see this COVID-19 family, it's an order of nidoviral family. It divided into the family of four: artriviridae, coronaviridae, mesonaviridae, and roniviridae. And this coronaviridae divided into again coronaviridae and toroviridae group. And this coronaviridae divided has got a genus of alpha, beta, gamma, and delta COVID. If you see the transmission of this COVID-19, the transmission takes place mainly through human to human during intimate contact with each other. And in early period, it was reported that this coronavirus affected near about more than 72% of this resident people around that area. And around 30% had travel history from the Wuhan, China city. Again, this recent research has pointed out that human proximity and social interaction increases this transmission of this virus. Among the several rates of transmission, the droplet are the primary source of transmission. Again, the picking the contaminated surfaces and touching face increase your risk of getting infected. In recent spread of infection through stool, they have also confirmed it transmit this virus. Again, in some cases, they also found the ocular surface is again responsible for this transmission. If you see the role of hand hygiene, what they found out that if you wash your hand at least 5 times per day, it significantly reduces your overall infection rate. The incident rate drops below around 0.35 with a significant p-value. And if you wash your hands after cough and or sneeze, it definitely minimizes the risk of transmission via household project. And there's again, it has got a significant incidence rate ratio on the lower side. There is a reproduction number, what is called the transmission of this virus from one person to other. for this coronavirus, the WHO defined initially this reproduction rate was around 3.5. And now for the today's scenario, in India, this reproduction rate is varied between 1.2 to 1.5 transmission rate, and in UK it is around 1.1 to 1.3. This transmission of this since 19, the average personal aerosol transmission is a major source. If you person stand between 4 to 5 feet, social distancing, that's why they recommend it should be at least 6 feet to avoid the transmission from one patient to other person. But in some countries, what they follow the rule, like in Australia, they are following 5 feet rule, 5 feet distance rule. In Denmark, France, and Lithuania, they follow the 3 feet rule. In one of the study, what they found out that there is a 13% risk of getting infected if the distance between two people is around within 1 meter. That means around 3 feet. And as this distance increases beyond 1 meter, there is a significant drastically reduce this transmission of the disease around 3% every increase in a 3 feet of distance. What are there are certain guidelines WHO defined for the medical personnel who are treating this infected patient. What they said, the medical staff who are treating infected patient should be isolated. Their routine activity must be monitored, and if they witness any problem such as fever, cold, cough, they need to be quarantined. The team of officials must check whether these medical personnel are following their preventive measures proper or not. Yeah, if you see this C19 virus, how many hours it remains alive in the surrounding area. What they found out that they live in the air for more than several hours. It can remain intact on the surface for more than 2 to 3 days. And further, again, what they observed, this virus could live up to 4 hours in copper and 2 to 3 days in a steel surface area. But in plastic, they may live longer. That really we don't have the enough. But there was no evidence for the cloth exposure, how much time they remain on the cloth. The WHO also come up with the transmission of C19 through the eyes. What they give some certain guidelines for this ophthalmologist. They said that this ophthalmologist should take proper precaution of maintaining hand hygiene, personal protection, as per prevention of this infection of SARS-CoV. This exposure of virus to the ultraviolet radiation and heating can control the infection. They again advise how you will sterilize. Means if you sterilize the instrument for more than 56 degree for 30 minutes with a lipid solvent, can make the ophthalmic instrument safe for the transmission. They put some certain guidelines for the dental procedure also, because they are exposed to patient very close in proximity, exposure to the saliva, blood, and body fluid. What they advise them, they should follow strict hand hygiene, use their personal protective measures properly, mouth rinse before the dental procedure. Knowing this travel history of the patient, they should document it. They also suggest for the anti-retraction handpiece, disinfection of the clinical setting, and handling of the medical waste properly. They have given certain guidelines for the endoscopy procedure. Like they advise like equipment should be used, mask, gloves, goggles, gowns, shield, and other respiratory equipments for the to prevent this outbreak of C19 from the patient. But the key ways of possible transmission during this endoscopy are mostly due to human contact, either droplet, air, and body fluids. What WHO said, and what the IDC guidelines also suggest, the transmission of this COVID-19 pregnant woman. What there's a certain article by Liu et al. What they found out, the pregnant women being are more susceptible this COVID-19 infection, but they reported no vertical transmission to the virus. But currently, again, we don't have the exact data 100% proved, well proved that there is no vertical transmission. It's still not 100% true. But what he found out, breast milk sample. Yeah, sorry, I think you will able to see the slides now. Hello. Yeah. Hello. Yeah.
Yeah.
What I now you see the
Yes, sir.
slides
We are
also.
able to see the slide, sir.
Yeah. There's the guidelines which I told you for the endoscopy procedure. What you have to follow. You have to just see the mostly you have to use your personal protective equipments while doing the procedure. And what are the basic methods, key ways which transmit the infection to the our consultant or our doctor through human to human or droplet or air body fluid transmit this COVID infection. And then transmission of this C19 in pregnant women. What Lee and Etiol, what he found out, the pregnant women are more susceptible to this COVID-19, and they reported there's no vertical transmission of the virus. Breast milk sample tested negative for the virus, and that's why he denoted that the breastfeeding can be done. Those patient mother got infected with the COVID-19. Sorry. Sorry again, I think. Yeah, you are unable to see the slide. I don't know what is happening. What they suggest is a diagnostic method and procedure to prove the C19 infection. The IgM and IgG is the simple technique which perform to diagnose this infected person. And what they found that IgG reported around 72% of detection rate. Beside nucleic acid test reported around 87.5%. And again, high sensitivity C-reactive protein, it is better with the nucleic acid negative group observed with a higher test positivity. That's why finally they said IgM and IgG are definitely better over the nucleic acid detection test, as it is highly recommended. Then second diagnostic procedure we are doing for the C19 is the CT image. They divided CT image into stage 1, stage 2, stage 3, stage 4. In stage 1, what we found out, like maximum patient number of patient with observed with a ground glass opacity around 75%, and lesions in a single lobe in stage 1, and consolidation. This is around most commonest feature. In stage 2, what they found out in CT, consolidation followed by crazy paving with multi-lobe involvement and peripheral lesions may be there. In stage 3 of CT imaging, we will able to get peripheral involvement, bilateral multi-lobe involvement, ground glass opacity, and consolidation. And in stage 4, the peripheral plus bilateral multi-lobe involvement, ground glass opacity, consolidation, and crazy paving pattern. If you compare what are the bedside tests we have available, like X-ray, CT, and ultrasound. In X-ray, the ground glass opacity you may able to see, but it's still not that sensitive. Compared to CT is much more sensitive. And in ultrasound, if you want to do the bedside for like evaluation, you will able to find out pleural line thickening and increase B line and consolidation of the air bronchogram you can able to see on the bedside UAG. If you compare CT finding versus RT-PCR, the definitely CT scan preferred over the RT-PCR when the patient carries the clinical symptoms of such as shortness of breath, cold, fever, and diarrhea. On the other end, the correlation between the RT-PCR and CT can be done to make sure the infected patients after the complete recovery. Sometimes you will get the false negative RT-PCR. The reason for this false negative RT-PCR either due to the insufficient viral material or laboratory error. Immature nucleic acid may be responsible for this. Insufficient viral load may be lead to the false negative RT-PCR, or improper clinical sampling also possible, or those patients with a low detection rate, and sometimes the manufacturing defect may be there. There are certain molecular assays evaluated for this COVID-19 diagnosis in US, in China. The Center of Disease Control and Prevention, they extensively working on this assay to target the genes like one, open reading frame 1B, second, RNA dependent RNA polymerase, third, non-structural P14 for the detection of COVID-2 with a high accuracy. And recently also about come up with a sorry. Just like that's why again. as I told you, CT image, comparison between the X-ray and CT ultrasound, CT versus PCR, I had told you, and what are the reasons for this false negative RT-PCR. And as I told you, these certain molecular assays are developed. And recently, this Abbott also come up with the ID now for now TM COVID-19, which can deliver the result within 5 minutes by targeting this RNA-dependent RNA polymerase gene. As a some of this were in China, which type of genes we are using this immunoassay, and this is called molecular assay we are using for this COVID-19. Yeah. So. Sorry, again, you lost the. Then again, I'm unable to show you the slide, but what is the outlook of this clinical procedure and treatment? Currently we have the 15 drugs which initially identified, which we are treating you are using to treat this COVID-19, like chloroquine, hydroxychloroquine, lopinavir with ritonavir combination, napstostat with chemostat, with famotidine, unifavir, ivermectin, corticosteroid, tocilizumab. Sometimes human immunoglobulins are also playing certain roles by they are containing natural antibodies and protein, which representing the first line of defense against this pathogen. What they found out in recent reports, the dexamethasone and remdesivir drug was widely considered as a life-saving drug because they have studied in more than 1,063 patients. It was convinced that this remdesivir is significantly reducing the symptoms and recovery time of the adult with the COVID-19 infection. But Indian scenario, definitely remdesivir is concern for us because of their cost, availability. So now, what is the prevention point of view, the vaccines availability? Currently, if you see the so many vaccines research is going on. Final first vaccine sanction got in UK is the Pfizer vaccine. This is the first one, and the second one is with the Moderna. They are also in the phase 3 and near sanctioning process. And if you see the in India, we have the Oxford vaccine. It's in a phase 3 trial and may get sanctioning within 10 to 15 days. Today, the news came that the Pfizer directly come up with a vaccine availability without bypassing the phase 3 trial, and it may be available in Wardha, Savangi from next week, either for the phase 3 or a direct inoculation. Really, that I don't know. This is the current scenario of the COVID-19. Thank you very much for IMA member, and I really, because of this technical reason, I'm unable to show you the slides. Hello. Thank you, sir. Vikrant sir. Thank you, Morko sir.
Hello.
Hello.
Thank you so much, Ashish sir. Thank you for adding to our information about COVID-19 infection. And in spite of the technical glitches, you could still carry on. That was really commendable. And we move on to the next speaker. And our next speaker is Dr. Lalit Raut. He is a hematologist, hemato-oncologist, bone marrow transplant physician, director of Aureus Institute of Medical Sciences, Nagpur. And his topic is crisis in sickle cell patient. So over to you, Dr. Lalit Raut.
Thank you. Good afternoon. Are you able to hear me? Okay. Thank you, IMA Amravati, for inviting me for this talk. And are you able to see the slides?
Yes, sir. Please go ahead.
Okay. So my topic today is management of sickle cell crisis. We'll start with basics. What is sickle cell disease? We know it is an inherited disease. Abnormality is in the hemoglobin, that is in the red blood cells. At the protein level, it's the amino acid level, glutamic acid is substituted for valine in the beta chain. And this structural change leads to polymerization of hemoglobin S, that is sickle hemoglobin, under specific conditions. which leads to cascade of events causing decreased blood flow, then tissue hypoxia, and then leading to acute and chronic organ damage. It is autosomal recessive condition. There is abnormality, that is missense mutation at chromosome 11 level. Now this structural change leads to abnormal polymerization of hemoglobin S in the setting of abnormal environmental conditions such as hypoxia or acidosis or infection or change in the temperature, either hypo or hyperthermia. These red cells adopt structural changes, leads to conformational change, and if we study the fluid dynamics at the microvascular level, there are alterations causing mainly the blockade of the microvasculature. And then the cascade of events starts, which clinically present as acute or chronic organ damage. Acute will be crisis and chronics are chronic organ damages. Let us remember that the problem here is not just restricted to red blood cells. The chronic inflammation here leads to chronic platelet activation. There is endothelial cell activation. N number of endothelial and protein adhesion molecules are overexpressed. This causes endothelial cell adhesion protein activation, and acute phase reactants are chronically elevated. Overall, this what leads to is increased thrombogenesis risk, and there are microinfarction in the affected organs. So the abnormality here is not just red blood cells, but it goes beyond red cells to affect endothelial cells, platelets, and cytokine formation, and which clinically presents as the abnormality in different organs. So wherever sickle cell reaches in whatever organ, then we can have the manifestations. So these are all clinical consequences of sickle cell disease. Today we will be dealing mainly with acute complications, acute infections, anemia, mainly hemolytic crisis, vaso-occlusive crisis, acute chest syndrome, and many more. We know traditionally we have been learning from our MBBS days that different types of crises are there: vaso-occlusive or hemolysis, acute chest syndrome, sequestration, whether it's splenic sequestration or it could be hepatic sequestration crisis. So we will concentrate mainly on the vaso-occlusive crisis. Most of all, we know that these crisis episodes are precipitated by certain factors. We need to know these factors because we can avoid them in future, and we can reduce the patient's admissions in hospital for crisis admissions. So common precipitating factors, we have infections. We have viral infections are more common in our region than bacterial. Then extreme physical exercise, dehydration, especially in the summer season, physical stress, psychological stress. So children with sickle cell disease appearing for 10th or 12th examination, at the time of examination, few days prior to examination, they will have vaso-occlusive crisis. Alcohol, pregnancy, and any other condition which can cause hypoxia or acidosis are all the precipitating factors for this crisis. The bundle of care in management of sickle cell includes all these sections, that is health maintenance, infection prevention, like vaccinations and penicillin prophylaxis, pain management, that is for acute as well as chronic pain syndrome, and sickle emergencies will be highlighting all these things. And of course, because it's a chronic disease, it affects lungs, it affects heart, it affects brain, it affects kidney, it affects bone. So all the respective fields, that is ortho, nephro, and cardio and pulmonary people are also involved in the management of this disease. The most important slide which I want to highlight today is when I'm talking on this topic, and if we read anything on this topic, we must remember that whatever is written, whatever we are doing, this is more of a experience based rather than evidence based. That means there are less number of clinical trials answering each and every question, but whatever is going on traditionally, that we are following. So when we have a child with acute painful cell crisis, we must remember that it is an acute medical emergency. We assess the pain using appropriate pain scoring tool. So this helps, we usually use Wong-Baker face rating scale. This helps to assess whether the drug is acting or not, that is the analgesic, and whether we need to increase its dose, or we need to add another analgesic, that is for step-laden pattern of analgesia. So that's why this scoring scaling of pains is very important. Second thing is, we must always remember to administer analgesia as early as possible. In fact, many times I advise people to consume analgesia at home and then don't wait for analgesia to be administered at the hospital, because earlier we start the analgesia, the duration of crisis pain, duration of crisis syndrome reduces. Apart from clinical assessment, that is TPR, BP, and saturation, we should always ask for the precipitators, and we should always look for any alternative diagnosis of pain. For example, if a child is having pain in the hip region, then in addition to just vaso-occlusive crisis causing pain, we must also look for if there is AVN or any other infection. So analgesia, fluid replacement, and avoidance of the treatment of the environmental precipitator are the mainstays of therapy. So let's look at one each. First is hydration. Why do we hydrate people? That's because intracellular dehydration of red cells is associated with increased rate of sickle cell hemoglobin polymerization. So if we rehydrate the red cell, then the red cell polymerization of the hemoglobin reduces. So less polymerization, then the crisis will be lesser. Then question comes, what kind of fluid should we use? That is normal isotonic fluids or hypotonic fluids. So we have evidence from in vitro studies. What they did was they studied normal red cells exposed to hypotonic fluid, and they found that the red cell membrane stiffness reduces when the normal hemoglobin containing red cells are exposed to hypotonic fluid. Similarly, if what they did was they exposed the normal red cells to isotonic fluids there, and then they found that the stiffness is increased. The transit times through microvasculature is increased, and in vitro studies they do this in a human capillary system model called as microfluid model. So if the red cells are exposed to isotonic fluid, then the transit time is less. So accepting this principle in sickle cell patients, we use hypotonic fluids. What route we should use for mild crisis? Oral rehydration to be started at home, and if the crisis increases, then we shift to IV. Or if the pain is very severe, or patient is having, because of liver issues, if patient is having vomiting or obvious volume depletion is apparent, then parenteral rehydration is preferred. While doing so, we should remember that aggressive hydration is can cause hypervolemia, so and that should be avoided. And that's because patients may have any other conditions which may precipitate pulmonary symptoms. For example, if patient is hypoalbumic because of liver disease, then we usually try to avoid hypervolemia. Another practical issue is when we are hydrating with hypotonic fluids, then and if we are simultaneously administering packed red cells, then they are not compatible. So you need to use another IV site. Next step is analgesia. Mild pain, if patient calls you and starts, child has started having mild pain, ask them to start analgesics, starting with lowest, that is paracetamol, and then gradually increasing according to the severity. If the patient visits hospital, you remember that it is an emergency. We, apart from other routine evaluation and hydration, we assess the pain level, treat it. If patient was already on opioids, we don't withhold it, but we try to increase it up to other level. We assess the pain control frequently. This is especially important to reduce the medication or to increase the medication, as well as to control the side effects like respiratory depression. So all these analgesic, if mainly opioids can cause respiratory depression. So to avoid that, we just keep a watch. That is, we frequently reassess it. Mild to moderate pain, we use paracetamol. NSAIDs should be avoided. Moderate to severe, opioids are the first line of treatment. What we use is morphine, or if it is not working, then next step, we usually go on to fentanyl and other drugs. Next step is oxygen therapy. Important point is pulse oximetry to assess the SpO2 may not be reliable in certain conditions, especially in severe episodes. Why? Because sickle cell RBCs have decreased oxygen affinity and it will not give an accurate reading. Moreover, the increased sickle cells RBCs have increased unsaturated hemoglobin in the arterial blood. So the pulse oximeter reading may not be reliable. So in that situation, arterial blood gas analysis is best. In our institute, we use ABG only if patient is having severe symptoms. For mild to moderate, we usually use pulse oximetry only. Oxygen therapy, we know that it is used routinely, but usually it is not indicated. And why not? Because it has been shown that oxygen therapy has no effect at all on the duration of brain crisis. Even in acute chest syndrome patients whose PO2 is good, then it has been found that it is of no use. So unnecessarily we are wasting the oxygen. Moreover, increased oxygenation in the blood will suppress the erythroid production. And this later on, that is after discontinuation of therapy, leads to rebound crisis. So oxygen therapy should be used only if indicated clinically. What is the role of transfusion? There are different kinds of transfusion, that is simple transfusion or exchange transfusion. Simple transfusion means we just transfuse the blood, and in exchange we remove something, and then in exchange of that removal we transfuse this PRC. When should we transfuse the packed red cell? Usually there are two conditions here. Some people advise it blindly use 8 hemoglobin as the criteria in adults, or in some studies say that we should know the patient's baseline hemoglobin, and if the hemoglobin drops more than 2 from that, then we should use the simple transfusion. So for example, patient's hemoglobin is around 9 or 10 during routine checkup, and if patient has presented to us now in acute crisis, and now if the hemoglobin is 7 or falling, then that is the indication of simple transfusion. If we don't have the reading, then use 8 as the criteria, as we use in all other ICU patients. And how much to transfuse? Again, the target hemoglobin will be the patient's baseline hemoglobin value. So it is better to always to know what is the patient's baseline hemoglobin, that is hemoglobin when the child is asymptomatic. Exchange transfusions. Exchange transfusions means we remove the patient's sickle cell blood and we transfuse the sickle negative blood. We consider this a prolonged refractory vaso-occlusive crisis. And another condition is the patient's hemoglobin level should be near normal. So then only we can exchange it. But if the hemoglobin level is less, then only option is simple transfusion. How much to transfuse? Again, here we monitor the S percentage, and less than 30 to 20 is the target value. There are other conditions also which present with pain. So like hand, foot, mouth, splenic sequestration, cholelithiasis can cause acute pain, priapism, AVN, right upper quadrant syndrome. Basically, for all these syndromes, pain management principles is the same. So another complication what we see is sequestration crisis, usually seen in children less than 2 years of age. So pediatricians usually see these complications here. Suddenly the spleen size increases and patient becomes anemic. The spleen being a spongy organ sucks all the blood and can cause circulatory collapse and death. It is more common with sickle cell disease than with compound heterozygous status of S and C hemoglobin. Mainstay of therapy, again, IV fluid, cautious blood transfusion. Here we don't keep the target of baseline hemoglobin, because what is observed that once the crisis is reducing, suddenly the spleen size starts decreasing and the whole blood is pumped in the circulation, and then which can increase the hemoglobin or can cause hypervolemia. So here we just try to give transfusions to maintain the adequate oxygenation. So it could be 6 for some patients, it could be 7 or 8 for some patients. If the child has recurrent episodes, then splenectomy is the treatment. But nowadays, with good response to hydroxyurea, I usually advise splenectomy only if on optimal medical therapy, patient is having 2 or more episodes of splenic sequestration crisis, then splenectomy is indicated, but not without optimization of hydroxyurea therapy. That is, at least we should see the response on 30 milligram per kg per day. If that reduces the episodes, then well and good, avoid splenectomy. If not, then go ahead with splenectomy. Another complication is acute chest syndrome. It is one of the leading cause of death, defined clinically as acute onset of fever, respiratory symptoms, and new infiltrate seen on X-ray chest. Commonly, it's because of infection. Underlying pathology could be fat emboli or lung infarct. We treat it as if both or all the 3 conditions are present simultaneously. So we treat infections with antibodies and acute chest syndrome as per other guidelines like blood transfusion if required. Fever is very important in patients with sickle cell disease. Why? Because mostly they are hyposplenic. So it is like managing fever in a splenectomized patient. So even the ultrasonography showing spleen normal or less smaller size, even it has not reached asplenia. There is functional asplenia. So that's why we consider sickle cell disease patient with fever as any fever coming in a patient with splenectomized patient. So it is an emergency. So we assess patient clinically, do all the lab works, look for site of the infections. We give IV antibodies as per the criteria, and should be managed in hospital if required in ICU. So fever should be considered as an emergency and need admissions usually. No slide, no management slide will be there without slide on prevention of the pain crisis. We usually advise all these people, but we need to stress them in each visit. So whether child is consuming adequate amounts of fluid or not, ask the parents to monitor that. Then we try to talk to the school teacher also. and we need to educate them that how hydration of this child is important to them. Patient should always avoid visit to higher mountains and mountain conditions, because the change in height and as well as pressure can precipitate the crisis. Also, extreme temperatures, genetic condition, screening, genetic counseling are all part and parcel of the management of this. There are newer drugs. All patients keep on asking what are the new drugs coming in sickle, what is the new therapy coming in sickle cell disease. From last 2 to 3 years, L-glutamine, voxelotor, and crizanlizumab. These drugs received FDA approval in Trump era. Don't know why glutamine approval was pending so long, and suddenly it got approval. All these drugs are useful only for prevention of pain syndromes. They are not much useful in management of acute conditions. These are indicated with or without hydroxyurea. L-glutamine, it is specially said that these medications should be used only after optimal use of hydroxyurea. Then only these are tried. So to summarize, if possible, identify and treat the underlying precipitating factors of crisis, because we usually forget to that. We usually concentrate on treating the current condition, but precipitating factors should also be addressed. Hypotonic fluids are better. Oxygen therapy only when indicated, and avoid delay in administration of analgesia. And when on analgesics, especially morphine or other drugs, reassessing the patient every 30 minutes for severity, sedation, vital signs, and respiratory is important. Thank you.
Thank you so much, Lalit sir. Thank you for the very informative talk you have given. And you've really given a very good information on VOC and how to manage the crisis. So, and I must thank you and Ashish Ganjre sir for joining us from Nagpur. Thank you so much.
Welcome.
And now we move on to the next speaker. Our next speaker is our very own IMA member, Dr. Saili Jahagirdar. She's working as the Assistant Professor, Department of OBGYP, DMC, Amravati. And she's practicing OBGY since 2006. Scientific Chairperson, State OBGY Conference, MOX 2020. She has also written 3 chapters, 2 in Foxy textbook and 1 in International Springer edition. So let us welcome our sweet and simple person, simple gynecologist from Amravati, Dr. Saili Jahagirdar, and her topic is PPH bundle. Over to you, Dr. Saili.
Am I audible, ma'am?
Yes, ma'am, you're audible, ma'am.
First of all, a very good afternoon to all of you. And many thanks, our ADC, Dr. Rohankar sir, Dr. Vikram, for giving me this opportunity to present here. I'm sharing my screen now. Is my screen seen completely?
Yes, ma'am.
Okay. नहीं होते नहीं आता है नहीं ना स्लाइड्स नहीं मूव होते
Ma'am,
you're going to talk on
ma'am, your presentation and screen is okay, ma'am.
Can you see my
Ma'am, your presentation and screen is okay. You can start with the presentation, ma'am.
Okay. PPH bundle. Now, what is PPH? Postpartum hemorrhage is defined as a blood loss more than 500 ml from the genital tract during vaginal delivery, or 1000 ml during cesarean delivery, or any blood loss that affects the hemodynamic condition of the mother, that is, either reduces hematocrit by 10%, increases heart rate, or causes hypotension within 24 hours of delivery. Now, this postpartum hemorrhage is an acute, unpredictable obstetric emergency. The incidence is quite high, around 10%, and is a major cause for maternal mortality and morbidity. It cannot be completely prevented. However, with timely diagnosis, a good teamwork, and the use of PPH bundle, we can save lives. Now, all of you have seen this gully cricket and professional cricket. What do we see in gully cricket? The team members of gully cricket are equally good, but there is no good teamwork. So the outcome in gully cricket is often unreliable. And when it comes to professional cricket, we have a coach who trains them how to perform unitedly. And so the outcome of professional cricket is always better than in gully cricket. So gully cricket is like tackling an emergency as it comes. Whereas in a well-trained professional team, the players play in unison with their responsibilities well defined, and they're fully prepared to tackle any emergency as it comes. What do we ultimately want? We want success. That is what everyone wants and every doctor wants. We want to keep our patient alive, healthy and well. So of late, we are trying to achieve this goal of tackling PPH by the bundle approach. Now, what is a bundle? A bundle is a set or collection of interventions that, when performed together every time a diagnosis is made, or when a specific clinical condition is recognized. When all components of the bundle are performed together, they result in better patient outcomes than when each intervention is performed single. Now, what do bundles help us? Bundles think differently. They increase the efficiency of the intervention, they avoid missing interventions, and they improve team performance. The bundle approach to PPH helps to reduce the problems of PPH by integrative, a comprehensive, and organized approach during postpartum hemorrhage. Now, this PPH bundle was designed by Dr. Thomas Burke and his MGH Boston team in January 2018. With the help of principal investigators of 10 medical colleges and 2 years of massive efforts of each one, the PPH bundle came into existence. I am very proud to share that Dr. Pushpa Zungare ma'am and myself were a part of this project, which ran for 2 years. Now, coming to the PPH bundle. In these 2 years, we devised this small card, that is the PPH bundle card. It gave a short description about what to do in case of emergency in case of PPH. The card has some pictorial figures as well as some written part. And this card was distributed after it was made. We held workshops for obstetricians, for the sisters, nurses, even at the PHC level. And then we distributed this card to wherever the delivery was conducted. This card was very useful, and it gave a pictorial image of how to manage a patient when there is PPH. Now, this card has 2 components, a clinical component and a non-clinical component. Now, we will go to each component. First of all, we need to prevent PPH. Now, to prevent PPH, what we need to do is we need to actively manage the 3rd stage of labor. So that is the preventive aspect of PPH. So there are 3 components in management of 3rd stage of labor. One is to start oxytocin, that is injection pitocin, at the time of the delivery of the baby. Second is, once the delivery has taken place, you try and deliver the placenta, not by pulling it, but by controlled contraction. So this will prevent inversion of the uterus and thus prevent postpartum hemorrhage. The 3rd intervention is to gently massage the fundal portion of the uterus so that the uterus contracts gradually. So these 3 components are to be done for every patient as a part of active management of 3rd stage of labor. And this is a major step in preventing postpartum hemorrhage. Now, there is some routine care which we do for all patients who deliver so as to prevent the patient from going in PPH. One is, after delivery, you check the vagina and cervix for any tears and repair them so as to prevent traumatic PPH. Second, you see that the bladder is empty. If the bladder is full, the patient has more chances of going in postpartum hemorrhage. The third intervention is you put the baby to breastfeed. If the baby starts breastfeeding immediately after delivery, then oxytocin is secreted and that helps in contraction of the uterus. So these 3 measures are taken so as to prevent PPH. Now, even after doing all these measures, that is active management of third stage of labor and also the preventive aspect, if still the patient continues to bleed, it is labeled as postpartum or primary postpartum hemorrhage. Then what next you do? The next thing is call for help. You need to call all the persons around you, all your sisters, your senior doctors who can come and help you, because PPH is an emergency. You never know how many people will be required to manage the patient. So the first thing you do is call for help. Then what next? Once you know that the patient is PPH, you activate the first response bundle. Now, what is the first response bundle? It has 4 interventions: uterine massage, IV fluids, uterotonics, tranexamic acid. So they are the 4 components of the first bundle. So once you have seen that the patient is having PPH, call for help and activate the first response bundle. One patient who's at the leg end of the patient delivers uterine massage. The second person starts IV fluids. The third person gives uterosonic drugs, that is pitocin or injection methogen or prostaglandins. And you also give injectable tranexamic acid, 1 gram, that helps to reduce the blood loss. So these are the components of first response bundle that have to be activated immediately. You know that patient is in PPH. Now, what are the essential measures? After activating the first response bundle, you want to rule out certain things. That is, you check again for tears in the cervix and vagina and repair them. If the bladder is not empty, empty the bladder using a Foley's catheter. Sometimes there is some retained bits of placenta inside the uterus, which may be the cause of bleeding. So you manually try and remove the bits of placenta. So basically, you have to tackle the non-atonic PPH. Explore cervix and vagina in OT under good anesthesia and illumination, and control the traumatic PPH. Empty the bladder, which helps in contraction of the uterus. And emptying the uterus is going to stop your PPH and also going to prevent your secondary PPH. Now, suppose the patient is in PPH, you have called for help, you have activated the first response bundle. Within 30 minutes, the patient still continues to bleed, does not respond to your first response bundle. Then what next? You need to activate the refractory PPH bundle. In the refractory PPH bundle, what we do is you try and stop the bleeding from the uterus. Now, how do you stop it? We have compression maneuvers. These compression maneuvers are going to reduce blood flow from the uterus to outside. We have 2, that is the bimanual compression and the aortic compression. What we do in bimanual compression is, one hand is placed inside the anterior fornix. The second hand is placed on the suprapubic region over the uterus. And in between both these hands, we try and compress the uterus. So if the uterus is compressed, naturally the bleeding is going to stop. But when we do bimanual compression, the problem is there is some amount of pain to the patient. Second, we cannot do any interventions from below, that is vaginal interventions cannot be done when we do bimanual compression. The second is abdominal aortic compression. Now the principle is, when you put your fist on near the umbilicus towards the left of the umbilicus, press down. What we do is we compress the aorta on the vertebral column. So if we push down hard and the aorta gets compressed, naturally the aorta is a major blood supply to the uterus through the uterine arteries. So when you give a good compression, aortic compression, this is going to reduce the blood flow to the uterus. Now, when do we do these 2 steps? Bimanual compression can be easily done in the labor ward, and it is also helpful to reduce the uterine bleeding. Whereas, if you're going to do some manual vaginally or you're going to do some suturing vaginally, then we can take help of some other person who will do aortic compression so that the blood loss reduces and the person who is at the leg end can easily suture the cervical and vaginal tears. So both these maneuvers are extremely useful in reducing the blood loss. But these are temporary measures to reduce blood loss. The second and the most important intervention is putting an ESM uterine balloon tamponade. Now this ESM uterine balloon tamponade is a very good device which was given to us by Dr. Thomas Burke. It's just like your silicone Foley's catheter with a condom at the top. The ESM UBT is inserted inside the uterus and then the condom is inflated with normal saline till the uterus becomes quite hard. So what the ESM UBT does is, in between the uterus, it tries to compress upon the uterine vessels and it stops bleeding. Now this ESM UBT can be placed for 24 hours inside the uterus, and gradually, once the uterus starts contracting, the normal saline is removed and then the whole ESM UBT is removed. Now this is a very, very useful device and helps in controlling postpartum hemorrhage. The second is the non-pneumatic anti-shock garment. Now this anti-shock garment, suppose if you do not have measures to do a surgical intervention for the patient is delivered at a primary healthcare center and you do not have personnel or you do not have enough medicines to control this PPH, you need to transfer this patient to a higher center, but the patient is in shock. Then how will you transfer the patient? So this non-pneumatic anti-shock garment can be worn on the patient, UBT can be inserted, and then the patient can be shifted very safely to a higher center. So till the patient is transported, this garment prevents the patient from deteriorating or going into further shock. So it's a life-saving garment. Now, what are the supportive measures? Now, once you know that the patient is having refractory PPH or is keeping on bleeding in spite of your measures, replace this blood. Till now, you were only giving crystalloids, but with such a large amount of blood loss, we need to replace it with appropriate blood components. So if blood components are also not available, then patients need to be transported to higher center where these are available. The second is, if you cannot manage the PPH with medical measures alone, you need to intervene or you need to start surgical management. What surgical management we do? One is, we do systematic devascularization. That is, we do the uterine artery ligation or the ovarian artery ligation, and finally the internal iliac artery ligation. We can also do compression sutures on the uterus, that is the B-limb sutures, on the Heyman sutures. If at last, if the bleeding does not stop with all this, we can go ahead with the obstetric hysterectomy. However, all this surgical management may not be available where the patient has delivered. So, the patient may need to be transferred to a higher level or the tertiary care center. So, we need to make arrangements for transfer of the patient to this higher center. So, by the time the patient is to be transferred, we have to use, as I told you, this ESM UBT and non-pneumatic anti-shock garment. So the first response bundle is activated. Then we put a ESM UBT to prevent further bleeding. You apply the non-pneumatic anti-shock garment, and then with all this, you can safely transfer the patient to higher center. So till the transport occurs to higher center, the patient is safe. But instead of doing all these measures, we have done the active management of third stage of labor. We have done all preventive measures. If PPH occurs, we have started the first response bundle. Then still, why do we fail in handling PPH? Maternal death reviews have found that delay in diagnosis of PPH, delays in use of recommended interventions, and disorganized use of multiple interventions is a key contribution to save a woman with PPH. So something more needs to be done other than all this emergency care, other than all these interventions, other than all this compression, the ESM UBT and non-pneumatic shock garment. We need something more so as to prevent morbidity and mortality due to PPH. So this is nothing but the non-clinical components of the PPH bundle. Now, the non-clinical components is a new concept, but it is equally neglected. Using non-clinical components definitely improves and it is rewarding in the long run. Now, what are these? The first is the teamwork and communication. What does teamwork mean? Teamwork means whenever you're handling the patient of PPH and you're calling for help, you have 3 to 4 people around you who are going to help you. But when you start managing that PPH, each one of your team members should know what work they're going to do and should be able to effectively communicate in between that what next they're going to do. If you think that a minimum of 4 people are required to handle PPH, there is a group leader and there are people who are assisting you and the roles to each people. So this is a long talk, but I'll tell you in short. There is a one person who is at the leg end who does the bimanual uterine compression, who manages traumatic PPH. Then you got the sister and you got a communicator. The sister does the job of putting an IV line, adding uterotonics, and giving tranexamic acid. The communicator goes and talks with the patient relatives, goes and arranges more help, goes and talks to the ambulance person. So he does the work of communicating the patient's condition with the relatives and with other people or at the tertiary level. So if the patient needs to be transported, it can be done very easily. So this is a very important component of the PPH bundle. And this, if done very properly, helps in better outcome of the managing the patient. Second component is facility readiness. Suppose you have all 4 people around you who are very much senior or very much good in tackling PPH. Suppose the patient needs to be operated, but you do not have a good OT facility. Even though you have got good people around you, but still you cannot manage the patient. So the facility where you are handling the PPH patient should also be equally ready. That is, the labor ward should be completely prepared to handle the patient of PPH. The OT should be completely prepared. The blood bank should be informed well in advance that you are handling a patient of PPH. So this facility readiness, if there 24/7, you can manage a patient of PPH whenever she comes. The third part is network integration. Network integration means there should be some form of communication at the PHC where the patient is delivering to the tertiary care center where you might need to refer the patient. So if this network integration is there, suppose the patient has delivered at PHC and she needs to be transferred, and you have already informed the tertiary level center that so and so patient of having PPH of blood group say B positive is going to arrive at your place. We have done all the components of the first response bundle. Patient is already on uterotonics. Patient has ESM UBT in place and a shock garment has been placed. And next, what you need to do is you need to do surgical management. Then the tertiary care center where the patient is going to be transferred is already ready with the OT. So when the patient reaches the OT, she is already on table. So this is the way network integration takes place. So if this is done, obviously the outcome of that patient is going to be better. So in short, the PPH bundle has clinical and non-clinical components. The clinical components form the PPH emergency clinical care, whereas the non-clinical components, that is teamwork and communication, facility readiness, and network integration, all these together form the PPH bundle. So if this PPH bundle is, we do it for every place wherever labor takes place, definitely we are going to reduce maternal morbidity and mortality due to PPH. Making one person smile can change the world. May not be the whole world. Thank you.
Thank you so much, Dr. Saili. That was indeed a wonderful presentation. I think your presentation was much like the professional cricket and not like the gully cricket. Very systematic. You've given us wonderful practical tips and you've given us the non-clinical and clinical components of PPH as well. So thank you so much, Dr. Saili. And we move on to the next speaker now. And our next speaker is Dr. Amit Kavimandal. He's got a mind-boggling CV. He's done his MBBS from KEM Mumbai, MD Medicine from AIMS Delhi, and DM in gastroenterology from AIMS Delhi. He has a number of publications and poster presentations to his credit, and awards in galore, I should say. Just to name a few, I would say they are Raje Bahadur Heart Foundation Gold Medal, Shatayushi Best Medical Student Award, MUHS Gold Medal, Dr. Shivarkar Prize, Wagbhat Memorial Prize, and the list goes on. So I wonder how one person can achieve so many gold medals in such a short span of time. That's really great, Dr. Amit. And over to you for your talk. And he's got a very interesting topic today, and the topic is non-alcoholic fatty liver disease. Yes, over to you, Dr. Amit Kavimandan.
Thank you, ma'am. Am I audible? Am I audible?
Yes, yes.
Okay, thank you. Thank you, ma'am, for such wonderful introduction. And thank you, IMA Executive Amravati, ADC, Dr. Vikram, for giving me this opportunity. So I'll share my screen now. Okay, so what we're going to talk about today is emerging, I would not say an emerging, it's already an established pandemic in along with COVID-19. It's a very, very serious disease which our country is facing. And the unfortunate part is that many of us are not aware about the disease. So fatty liver, you must have heard it about many times that ultrasound was done for some other reason and you found out that there was fatty liver. So we always think that it's a minor innocuous disease, but that is not the case. So what is actually fatty liver disease? It's accumulation of fat in the liver in the absence of recent or ongoing intake of amount of alcohol, because alcohol also causes fat deposition in the liver. So if somebody is having fat deposition, significant alcohol intake. So obviously the question is going to arise, what is the significant alcohol intake? And that is everybody is going to ask. So मेरे लिए क्या safe है? So cutoff is up to 20 grams per day. So in layman terms, 10 grams of alcohol is present in 30 ml of whiskey or 100 ml of wine or 250 ml of beer. So anything more than 2 drinks is significant alcohol intake. Also, there are some other secondary causes like hepatitis C infection, bariatric surgeries, TP, and some medications, and some inborn errors of metabolism which can cause fatty liver disease. So there's a spectrum of NFLD, non-alcoholic fatty liver disease. Commonly what we see is a simple fatty liver called steatosis. There is just accumulation of fat in the liver. Then this fat causes inflammation and fibrosis. This is called as non-alcoholic steatohepatitis. There is fat, also there is inflammation. So this is NASH. This is the second stage. And if this remains unchecked, next comes is cirrhosis. There is the loss of hepatocytes and the scar tissue is replacing the normal hepatocytes. That is the deadly end of this disease. So how common is NFLD? You'll be surprised to know it's fairly very common. If you can see in this graphic, it has been seen in various studies that NFLD comprising all, that is steatosis, NASH, cirrhosis, can be seen up to 30% of normal Indian population. Out of these 30% patients having steatosis, 7% can have NASH. Out of these 7% of patients having NASH, 25% can have NASH-related cirrhosis. And out of this 25% cirrhosis, 60% can develop liver failure, and almost 20% of them can develop a malignancy in the liver, that is hepatocellular carcinoma. So it's a serious disease. So what are the risk factors for NFLD? We all know obesity is the major risk factor. Diabetes, again insulin resistance, then abnormal lipids, that is low HDL, that the good HDL is low, and high triglycerides. You can see all these are interlinked. Insulin resistance causes diabetes, obesity causes insulin resistance, and all of these combine together to form low HDL and high triglycerides. So all of these are important risk factors for NFLD. As I alluded to earlier, the prevalence of fatty liver, that is simple steatosis, seen on ultrasound, is very high in Indian population. You can see the blue bars are urban studies, which have shown that almost 30% of urban Indian patients have steatosis if you do their ultrasound. These are, mind you, asymptomatic patients. And if you do the same study in diabetic patients, this percentage can go up to 88%. And not only that, we might think that obesity, diabetes, all these are problems of urban patients. No, this is quite prevalent in rural population also. There is a study from West Bengal, supposedly a poor state where the rural people are poor, the BMIs are low. Even they found out that 10% of population there, asymptomatic general population, had fatty liver disease. So that is very alarming. And studies have shown that Indians are more prone to NFLD. It has been seen earlier also that Indians have lower BMI cutoffs for obesity. If you all know, Western cutoffs for obesity are different. Indian cutoffs for obesity are different. We have obesity at lower BMIs also. So, and it has been seen that patients who are not obese in India can also have fatty liver disease. We have very high prevalence of diabetes mellitus. We are going to be soon the world capital of diabetes. We have very high central obesity, high insulin resistance. We have very high hepatic triglyceride concentration. And as I said, 8% of patients of fatty liver disease are lean. They're not overweight, they're not obese. So that is very risky. So, and NFLD is just the tip of the iceberg. As we saw earlier, insulin resistance, obesity, diabetes, all are interlinked. So NFLD, if you see, patient is underlying having a metabolic syndrome, insulin resistance, hyperinsulinemia, central obesity, dyslipidemia, hypertension are all going to be there beneath the surface. So how do they present? They are mostly asymptomatic. Sometimes they can present with right upper quadrant pain, which may be vague. They may present with fatigue, or if somebody is unfortunate that he's already developed cirrhosis, they may present with complications of liver disease like GI bleeding, ascites, pedal or encephalopathy. Also, they may have associated other complications of metabolic syndrome like obstructive sleep apnea. Obstructive sleep apnea is a very poor prognostic marker of overall metabolic syndrome also. And they may have complications of metabolic syndrome like hypertension, coronary artery disease, kidney diseases, strokes. So they may have. So how do we evaluate? If you do a liver function test, most of them will have normal liver function test or mildly elevated SGOT, SGPT. We have to rule out other causes of liver disease like hepatitis B, hepatitis C. Autoimmune liver disease can also cause sometimes fatty liver or abnormal LFT. And in fatty liver disease, 30% of patients can have positive anti-nuclear antibodies, but they are usually low titer antibodies, and these are false positive antibodies. Other workup may show increased ferritin. Again, this is showing increased ferritin is related to inflammation and insulin resistance. So how, on imaging, see, the commonest way a patient is diagnosed as fatty liver is by doing an ultrasound. So fatty liver is seen when the fat occupies almost 30% of the hepatocytes. Commonest imaging modality performed is ultrasound. And as we all know, you have seen the reports, grade 1 fatty liver, grade 2 fatty liver. Grading on ultrasound is not associated with severity of inflammation or fibrosis. So that is just a subjective assessment. Also, CT abdomen is a very sensitive test to diagnose fatty liver, but it is costly and causes radiation exposure also. And MRI with spectroscopy and elastography, it is best for assessment of fatty liver disease, but it is highly costly and obviously time consuming. So how do we diagnose? The gold standard for presence of, just presence of steatosis does not mean much. You have to detect inflammation and fibrosis. So to detect inflammation, the gold standard is liver biopsy. You have to put in a needle inside the liver, take out the liver tissue and examine it under your microscope. It is important to differentiate between steatosis and steatohepatitis. So on liver biopsy, we may see macrovesicular steatosis occupying at least 5% of the hepatocytes, but obviously it is highly invasive. Patients can have complications, pain, bleeding, sometimes bowel perforation. and you cannot do liver biopsy again and again. Like you have done a liver biopsy for diagnosis, you give some treatment and you want to see improvement. The patient is not going to come back to you if you say that I want to do liver biopsy again. No way. Again, liver biopsy, it depends on where you do. So there may be sampling bias. Sometimes the position where you've done the steatosis may not be severe, inflammation may not be severe. So we're looking for something non-invasive tools for assessment of NFLD. So the important tool which has become available is called as transient elastography with CAP. So this is basically a ultrasound-like test called as commonly known as fibroscan or a fibro test. What we are doing is, so basically what it does is it gives passes a sound wave through the portion of liver, and the reflection of the sound wave is calculated, and the time taken for this reflection gives us the assessment of stiffness of liver. If there is fibrosis in the liver becomes more stiff. So more stiff liver, more fibrosis. So it gives us a measurement of liver stiffness measurement, and it is directly correlated with fibrosis. There have been multiple studies over the past, say, 10 years or so, that they have done liver biopsies and done fibroscan, and they have shown that it correlates very well. And also an addition is that new method is added, that is CAP. It gives us the level of steatosis, how much fat is in the liver. So it is basically measures the impedance, acoustic impedance of the liver. So this is the very handy machine that we have at our hospital also. We're using it regularly. So you can do a fibroscan. It's a non-invasive 5 minutes procedure like an ultrasound. You put the probe on the intercostal space on the right side where the liver is located. You take 10 readings and the machine gives you an average of the readings, and we can assess the fibrosis. So the report comes like that. We get the stiffness. So stiffness is here, and this is CAP. This is the assessment of fibrosis. And we have the scale also, like I'm going to talk to you in the next slide. So this is the correlation between the fibroscan values and the histology. So the histologically, the fibrosis is classified from F0 to F1. F0 is there is no significant fibrosis. F4 is cirrhosis. So we have the values of fibroscan correlate with this levels of fibrosis. So if the fibroscan value is below 7, there is no significant fibrosis. 7 to 9.5 is significant fibrosis. 9.5 to 12.5 is severe fibrosis, and 12.5 and above is cirrhosis. So within 5 minutes, we can detect whether this patient has fibrosis. As we seen earlier, steatosis is very common. It is very essential to detect fibrosis because that determines the prognosis. These patients are likely to go into cirrhosis and liver failure and complications of cirrhosis. So this is a very good non-invasive tool. It is widely used and validated. It is fast, reliable, reproducible. It is very accurate. It can exclude cirrhosis and give a prognostication, and can be used in children also. Obviously, liver biopsy very difficult to do in children, and it can be used for screening also. Like in diabetic patients, we've seen 88% of have fatty liver disease. So if you want to screen such patients, this is a very good tool because they are likely to develop complications. So we have diagnosed, we have assessed the level of severity, fibrosis. So how do we manage NFLD? Management is very important. And the most important, we start from the base of the pyramid, is lifestyle modification. You have to target the metabolic syndrome. We can use some liver directed drugs and manage the complications of cirrhosis. So the crux of lifestyle modification, as you can see in this graphic, the most important, the biggest circle I put is exercise and physical activity. That is the most important thing to manage fatty liver disease. If you reduce weight, do a regular exercise, your lipids will improve, insulin resistance will go. Even if the patient is not able to lose weight, but he is doing aerobic exercise at least 45 minutes to 1 hour every day, there has been shown to be improvement all the biochemical parameters, insulin resistance, the triglycerides, even if you are not able to lose significant amount of it. So that is very important. Energy restriction, reduce caloric intake, avoid sugar and alcohol. Patients who are taking alcohol also, it is very essential to stop because alcohol are all empty calories and alcohol will also damage the liver. And not only that, patients who are not taking alcohol, sugar is like alcohol. Sugar is as dangerous as alcohol, so it should be stopped. Even for others also, sugar is as dangerous as alcohol now, and it has been shown to be addictive also, as addictive as alcohol or some other drugs. And we can add micronutrients also. They are very essential, like zinc, selenium. These micronutrients decrease the inflammation, decrease the fibrosis. An important thing is coffee has been shown to be very beneficial to decrease the fibrosis and inflammation in liver. But coffee should be taken black, not with sugar or milk. Then we are decreasing the all beneficial effects of coffee. Coffee has a lot of antioxidants which are very useful. Then we've seen patients, we've given them lifestyle modification, then we use drugs. When to use drugs? Should not use drugs in every patient. Patients who are having significant fibrosis, that is fibroscan values above 7.3 or 7.5, we can use drugs. Or patients who are at high risk of progression, like who are more than 50 years of age, are having diabetes, are having abnormal LFT, drugs should be used. So what drugs are available? The commonly used drug for fatty liver disease is vitamin E. It was a landmark trial called PIVENS trial, which has shown that almost 800 milligrams per day of vitamin E was useful in non-diabetic NASH. But other studies have failed to reproduce the similar results. But yes, as a starting drug, vitamin E is a good drug to start in NFLD, just has mild to moderate effects. But it has some complications, like it can increase cardiovascular mortalities, can cause hemorrhagic strokes, and some studies have also shown association with CA prostate. Other commonly used hepatoprotective drugs like ursodeoxycholic acid is not useful, commonly prescribed all over, but it is not useful in fatty liver disease. Anti-diabetic drug pioglitazone has been shown to have beneficial effect on fatty liver disease, but the problem with it is it causes weight gain, so it is counterintuitive to the management of NFLD, and it also increases the cardiovascular risk. The S-adenosylmethionine, it has good animal studies data, but clinical studies data is not so good. Probiotics, silimarin, there are no data that they are useful. We have some newer drugs which have become available to us recently. One of the drug is
Hello, Amit sir. Hello, Amit sir.
saroglitazar. It is already approved for management Was I disconnected?
Yes, sir. Your network connectivity is not so good, so you was disconnected, sir. Please kindly start the screen sharing again, sir.
Okay, okay. So, okay. So did we hear about the, should I start again, or should I start from this slide only?
Start from this slide only, sir.
Yeah, yeah. Okay, okay. So this drug it is safe and well tolerated. Its phase 3 study is ongoing. Another drug, that is elafibranor, it is dual
Sir, I
PPAR
kindly
alpha and
request you
delta
to switch off
agonist.
the
It is
video.
also safe and effective. Phase 3 study is going on. Switch off the video. Okay.
Okay.
Better? So
Yes, sir. Yes, sir. It is good, sir.
Okay, okay. Thank you. So a newer drug which has become available, that is obeticholic acid. It's a farcenoid X receptor agonist. And a recent randomized control trial showed that it is causes significant reduction effects on insulin resistance and lipids, also causes in India in the past 6 months or so, and the results are encouraging. There are other anti-diabetic drugs which are incretin-based drugs like liraglutide, euphragloxin. These are also useful in management of fatty liver disease. And as we all know, weight reduction is very important for management of fatty liver disease. Patients who are not able to lose weight by exercise and diet control, the options are bariatric procedures. Either they can be done surgically or endoscopically. Also now we can put endoscopically intragastric balloons, or we can do a DJ sleeve bypass, or we can do an endoscopic gastroplasty. So these have shown good effects in management of diabetes also and fatty liver disease also. But the problem is that patients who are already developed cirrhosis, those have high risk for undergoing bariatric procedures. They may develop liver failure post bariatric surgery. And sometimes the earlier bariatric surgeries were using fat vitamins. So how is the prognosis? As we say, steatosis can progress in 50% of patients over a period of say 15 years. Out of this NASH, 50% can develop cirrhosis over a period of next 15 years. And once you develop cirrhosis over a period of next 10 years, 20% can develop liver failure and hepatocellular carcinoma. And as we've seen here, the progression is reversible if you arrest it at NASH. You can go back to steatosis and normal liver. But if NASH progresses to cirrhosis, then it is irreversible. So very important to identify patients who are in this stage, and you should be able to go back by treatment and lifestyle modification. Also, these patients have high risk of cardiovascular morbidity and mortality, and there are higher chances of developing diabetes mellitus. Anybody who is detected to have fatty liver disease and is non-diabetic over a period of next 8 years or so, 20% of them develop diabetes. The hazard ratio is as high as 4.8%. So very important is to selectively. And NFL country, I think it would be something like a second or third commonest cause of cirrhosis now. I thank you all for your patient hearing, and I thank you again. Thank IMA Executive Body and Dr. Vikram for giving me this opportunity. Thank you.
Thank you so much, Dr. Amit Kavimandan. It was a wonderful talk, and your talk really reflects that you are a true genius. It was in depth, and you have given us very practical tips also, especially regarding that sugar is, as dangerous and as addictive as alcohol.
Yeah.
Okay, and now we move on. Yeah, thank you so much. And we move on to our next speaker, Dr. Shripad Jahagirdar. He's done his MD and DNB in pediatrics. He's the director of Hope Hospital and national trainer for neonatal resuscitation program. He was the organizing secretary for Mahapedivon 2019. So we have already experienced his wonderful skills as an actor. And today we are about to experience his skill as a pediatrician, as an orator, as a presenter. So I think his patients, he might be a favorite of his patients because of his cool and calm nature. So let us move ahead, and over to you, Dr. Shripad.
Good evening. I will share my screen.
Sir, your screen is visible. You can start with the presentation, sir.
Okay, today we will discuss about picky eaters condition. Though this is not common for pediatrician also, but it is for every parents. So these are the things that probably all doctors or all parents should know how to deal with such patients. Okay, picky eaters, they are the children having strong food preferences, consume in an adequate varieties of food, restricting the intake of some food groups, eats a limited amount of food, and are unwilling to try new foods. These are the group of people, they will go on eating only one type of food, and they will not accept or they will not encourage in eating other variety of the foods. We call them as a picky eaters. So picky eaters, the most of the time symptoms onset starts from the age 15 months to 18 months onwards, and most of the time the symptoms resolve by 5 years. But these 3 years are really very painful for parents. These are very frustrating for grandparents. Why the child is not eating, why the child is having so many problems about the diet, even everything is available at home. So really a tough time for the parents during these 3 years. Child has a favorite food but cannot make do with other options. Child is upset if not getting a favored food, may become fussy for few hours. Preference for carbohydrate in such patients. This picky eating may be extreme if the child eating is affecting his social, emotional, or physical development and can causing family conflicts. Sometimes, most of the time, this is a self-limiting condition, will not cause much problem to the pediatric population, but sometimes deficiencies can occur because there is very choosy in eating and most of the diet is not consumed. So they can have a deficiency of iron, calcium, zinc, vitamins. The child's attention and energy level can be less. Child cognitive function can be decreased because of so micronutrient deficiencies. Immune system may be affected, recurrent infections, weight gain problems, dental problems may be possible. Now let's see what parent can do. So there are very simple tips. These are ideally for picky eaters, but we can take it for most of the eating problems for the children. For in most of the eating problems, same guidelines will follow. Parents has to be a role model, involve entire family. Patience is the key. Remember, even the parents can be one of the parents can be a picky eater when he was a child. So most of the time the parents complain that bachcha khata hi nahi hai. But always remember very simple rule. Parents can control what, where and when food can be provided. And child will always decide whether or not to eat the food and how much to eat. So we cannot control everything. We can control what child can eat, where child can eat, and when food can be provided. But we cannot control how much child can eat and whether child will eat or not. So it's his choice. Often other variety of age appropriate foods, your child should select from the variety of the foods at meal time, vegetable, fruits, protein, starch. The family menu should be limited up to 15 times before they can accept it. It is not a loosening condition. Hello. Hello.
Sir, you are audible, sir. Sir, you are audible. You can continue.
Most of the
Hello, Shripad sir, please kindly switch off your video. Over to Anuradha, ma'am.
Dr. Shripad, can you please continue? We can do it without your video also. Am I audible to you?
Yes, ma'am, you are audible, ma'am.
Yeah, am I audible to Dr. Shripad?
Ma'am, Shripad sir have left the meeting.
Okay, there's some issue with, okay, some technical problem. We'll wait for a minute and then we will move on.
Okay, now.
Dr. Anuradha, madam?
Yeah, yes, sir.
Yes, Dr. Shripad sir is joining from a different device. So
Okay.
he said he will present. Just
Okay,
give him a
okay.
minute. Yeah.
Yeah, we'll give him a minute. And it's definitely a very interesting and an important topic. In every household, of course, we face this problem of picky eaters, and we really don't know what to do. So definitely we would like to listen to him. Are you there, Dr. Shripad? Yes, over to you, Dr. Shripad.
Shripad sir, please on your mic, sir.
Okay. Share the
Shripad sir,
responsibility.
sorry to interrupt you. You can share your screen, but please switch off your video.
Okay.
Okay. So that will give you a better bandwidth.
Okay. Now slides are visible. I can talk from other thing. Hello.
No, sir, slides are not visible, sir.
Let me check. Okay. Now slides are visible.
Yes, sir, slides are visible, sir.
Your child should select from the variety of the foods at meal time. Vegetable, fruits, protein starch, the family meal should not be limited.
Shripad sir, your mic is not on, sir. Shripad sir, your mic is not on, sir.
Hello.
Yes, sir, you're
Child
audible
may
now,
not
sir.
eat the foods you provide, because if child is consuming too much amount of juices, soda or milk, then probably food intake may be less. So try to see this factor, and liquid intake in the form of soda or cold drinks should be avoided.
Sir, you're audible, sir. You're audible, sir.
Okay. So
okay. All thing is fine, sir. You're audible, sir.
But hello.
Yes, sir, you're audible. You can start, sir.
Okay, set a meal schedule, which is very important. Set the schedule of breakfast, mid-morning snacks, lunch, afternoon snacks, dinner, bedtime snacks. Let the child know that there is a meal coming every 2 or 3 hourly, and they will not go hungry. Avoid giving your child food between the scheduled times. If your child chooses to skip a meal or a snack, he or she can wait for the next scheduled time for a couple of hours. If your child refuses to eat, have him or her sit in the table until the other family member finish their eating. Not that I have finished my feeds, I will go from this dining place. Not everybody will start the dining at the same time, and everybody will be there till the last person finishes his lunch or snacks. Conservation should be very pleasant during dining. The eating place should be clean and bright with no distractions. And most important is, meal time is not the time for watching television or arguing. So most of the time, the food should not be decided by the what TV serials emotions captures. If the TV emotions are very serious or very frustrating, then child may not eat. So TV watching is or mobile watching is strictly avoided during mealtime. So everyone has his own quirks about eating. Respect that food that your child eats today may not be eaten tomorrow, which is very important. Mother always say, okay, last time whenever this food was prepared, everybody likes it and you also liked it. Now why you are not taking this feed? So this will not happen. Every time child may not like the same feed, or sometimes the child will like to have different feeds. Always offer some different substitute foods. If your child doesn't like or doesn't seems to be eating the food, then you have prepared for a meal or snack, it's okay. Avoid that temptation to return to the kitchen and start preparing another food which is favorite for the child. We will always say in this manner, okay, this is for today, tomorrow we can have, or day after tomorrow we can have the food that you like. Today whatever has been done is liked by most of us, and you have to accept that and you have to start eating these foods also. So our parents' nature or parents' attitude should be changed. Liking of the foods or acceptance of the food is not emergency. You can always tell, we will not prepare the food that you like today. Whatever has been prepared, you have to eat today. So if the child is forced to eat the entire meal before the dessert, he may be full by the time the dessert is available. So child may in between the feeds go to and take the dessert on his own. So if this is happening frequently, the parent should see that you can bring the dessert with the meal also, so that child can enjoy the meal, child can enjoy the dessert also. Again, the dessert should not be a rewarding condition, that you finish all this milk and you will get the dessert. This should not be the attitude for the parents. Even if the parents, child sometimes doesn't able to finish his lunch, still if you are offered dessert, then prepared for the dessert, then go with the dessert. Everyone in the family should enjoy the desserts. So these are the few take-home messages how parents or how everyone can deal with these picky eaters. So this is a mnemonic one can remember. P is prepare one food of their choice. I, involve your child in food making, decision making of kitchen. Cook variety of the foods. Patience is the key, which is most important for all the parents. No yelling at meal time, no fight at meal time. Eat with the family often. Avoid forcing meals. Decide timetable, and timetable should be fun time. Encourage healthy habits. Be a role model. Parents has to be a role model. Serve small portion of the feeds. Okay, thank you. Though it is a difficult, theoretically it looks simple, but when is a practical pediatric patient is there, it is always difficult for the parents. So patience is very important. That is, I always tell the parents. Thank you very much.
Thank you so much, Dr. Shripad Jahagirdar, for a wonderful presentation. We really got very practical tips from your talk, especially the wonderful way in which you have made the acronym Picky Eaters, and you've given the summary in a beautiful way. Very important tips like being the role model and not watching television at the time when we eat food. All those will be very, very useful to all the listeners. Thank you so much.
Thank you.
And now we move on to our next speaker. Our next speaker is a young and dynamic otorhinolaryngologist and a rhinoplasty surgeon from Amravati, and also a visiting rhinoplasty surgeon at 7-Star Hospital, Nagpur, and so many other cities like Aurangabad and Surat and Nanded. He's one of the founder, directors, and founder secretary of ARSI, that is Association of Rhinoplasty Surgeons in India. He has been honored by the first Wolfgang Gubisch Gold Medal, the rhinoplasty surgeon of India, by the world leader in rhinoplasty, Dr. Gubisch himself. And that is not all. He has also received the prestigious RAF Cooper Award and ARBD Award and many other awards for his original work in rhinoplasty. He has performed more than 1,000 rhinoplasty surgeries and is invited as an operating faculty all over, I should say, even regional, national, and international conferences. So, in short, I could say that he is so much in demand that we can call him the most wanted ENT surgeon of Amravati. So, over to you, Dr. Kshitij. And his topic today is also one of the most useful and very interesting topics, that is aesthetic rhinoplasty.
Thank you, madam, for the wonderful introduction. Am I audible properly?
Yes, sir, you're audible, sir.
Okay. Thank you for the wonderful introduction. And at the outset, I must thank Team IMA and Dr. Vikram Deshmukh for considering me for this talk on this platform. So let's start with our talk today. So I'll share my screen right now. Okay, so now with the advancement of nose surgery, we have a lot of patients who are having breathing difficulties, and also patients who are consulting us with some expectations like Doc, make me beautiful. So here I'm going to talk about some nasal tip techniques and tricks that I generally use in my surgeries. So it is said that he who masters the tip surgery masters the rhinoplasty. So this is one of the last portions of the rhinoplasty surgery, which is one of the most difficult tasks to master. Why is this surgery so difficult? It's because of wrong analysis, the various skin thickness in our population, limited soft tissue covering. Looking at the ideal nose tip aesthetics, the nose on the front view should have a dorsum which is high enough to cast shadows on both the sides, and on the basal view, the tip should be triangular, and the tip width should be equivalent to the width of the philtrum, and the columella show of about 1 or 2 millimeters. And the nose should have a gull wing on the front view in flight. Because it's a general topic, I would like to just have a little bit nomenclature correct. So this portion in front of the eyebrows is called as radix area, then is the rhinion, then is the supratip area, then the supratip lobule, tip lobule, infratip lobule, columella, this is the nasal ala and ala rim. We can skip that. Now, the tip can be compared to a tripod. It has a tripod having 3 legs. So by altering the length and the height of one of the 3 legs, 1 or 2 of the 3 legs, you can alter the height and the positioning of the nasal tip. So there are different kinds of ala and columella relationship. So on the lateral view, when you draw a line like this, the vertical line, it should be divided into equal halves. So now if one of it is less, then it is called as a retracted ala. Otherwise, there can be a combination of these two things. There can be a hanging columella, there can be a combination of retracted ala, and there can be combination of any of these things. So in our country, as we all know, the regional variation is, there's a lot of regional variations in different parts of India. As we all know that in northern India, we have long noses. In southern India, we have generally short noses. The northeast noses are different, and even the western populations have different kind of noses and the skin structure. But we all have our heroes, and all of us would like to look like our heroes. So all of them have a good characteristic of the noses we should consider. But when we consider broadly, the North Indian noses are long noses and the South Indian noses are generally short noses. So these can be compared to Caucasian type of noses and non-Caucasian type of noses. So the Caucasian type of noses, they generally have long cartilages and a thin skin and very less amount of fibrofatty tissue, as opposed to the South Indian noses. They have weak cartilages, thick skin, and a lot of fibrofatty tissue. So the North Indian noses generally require only tip sutures, and the South Indian noses generally require about tip grafts. So in North India, the tip light reflex generally show about 2 tip reflexes, as opposed to the South Indian skin, they generally have only 1 light reflex. So it is called as a bi-tip, and the South Indian noses, they generally have a monotip kind of an appearance. Looking at the ideal nose tip aesthetics, we generally have a nasolabial angle of about 95 degree in 95 to 100 degrees in females, and in males it is about 90 to 85 degrees. So let's consider some tip sutures. So at the end of the surgery, we would like to have this tip diamond. So it has 2 tip defining points. This point is a columellar lobular angle, which gives you a columellar break point, and the point above that is generally a supratip break point. So to reduce the bulk of the supratip area, we generally just do cephalic trimming of the lateral crust. So cephalic trimming means you remove this part of the cartilage, the upper part of the cartilage, which makes the bulk, and this considerably reduces the tip width. The video is not playing somehow. Anyway, so sometimes you can just infold it to gain the same appearance if the cartilages are weak, and if you do this maneuver, then it may lead to collapse of the lateral wall. So in such cases, you have to reconstruct. The video is not playing somehow. Columellar strut, to give a good projection. Projection is when your nose points out of your face. To give a good projection, you may insert a strut like this, and this gives you a good tip projection. And then the sutures, tip sutures. So after doing this maneuvers, you have to, you may take tip sutures to actually narrow down the tip. So these tip sutures are taken to narrow down the tip. So this is transdermal and interdermal sutures. So after taking this transdermal sutures, you may suture this tip cartilages together. So this is the dermal equalization suture or a transdermal suture. Then to bring your lateral crust together, you may consider a lateral crural spanning suture. So now let us consider a few examples. This 21 years old female comes with breathing difficulty and a very broad tip and also a hump on the nose. So on opening up, apart from the hump, she had huge alar cartilages, and we did a cephalic trimming and the columellar strut and tip sutures. And here she is after about 2 years after the surgery, and here she is after 7 years after the surgery. So you can see that the tip width is about 2 centimeters, and we have reduced the tip width to a much nicer extent. And these are the long-term results. And even after 7 years, they have wonderful results. Similarly, this is a revision case. You can see the tip width to be about more than 2 centimeters, 3 centimeters, and post-surgery, immediately, even though there's a lot of edema, the patient has a very beautiful tip. After the surgery, this young girl, 25 years old female, comes with a hump, a hanging columella, and a boxy kind of a tip. So we did a tongue in groove technique for this patient. So because to treat the hanging columella, so this is a setback of the columella. So you have to anchor the medial crus to the caudal septum. And this gives you, this is the treatment for a hanging columella. So as you can see here, the hanging columella, which was there, it's got treated nicely. In addition to that, we also got a straight dorsal profile and the hanging columella got treated. The boxy tip, square type of tip is also treated and the patient is very happy and she has a good breathing and a beautiful nose at the same time. This gentleman, aspirant model, also had a breathing difficulty. So we accepted him for the surgery, and post-surgery, as you can see here, he had a big hanging columella which was treated. There was a deviation which was treated correctly, and a huge hump was taken off to give him a straight profile and a wonderfully balanced dorsal. Other similar examples using the same technique. Now tip rotation, coming to tip rotation, some people have a downward rotated tip or an upward rotated tip. So again, remembering the Anderson's tripod principle, we may shorten or lengthen the one of the legs of the tripod to alter the angle of the tip. As you can see here, this patient had a very droopy tip and this nasolabial angle was about 45 degrees. So we did a tip rotation suture or a tip suspension suture in this case. So for this, we pass a needle through the columella and a suture material is fed through this needle. The needle is withdrawn. This is then tied to the anterior septal angle and a similar maneuver is done. Okay, there seems to be a problem. Am I audible?
You're audible, Kshitij.
Okay, just give me a moment. I'll just restart the presentation. Okay, I'll share my screen again. So here is this gentleman with a droopy tip, which was about 45 degrees. It was treated to about 85 degrees. And as you can see here, this droopy tip was also treated very nicely. In addition to that, the hump is also gone and he could breathe nicely. Other similar examples, a droopy tip treated nicely, a perfectly 95-degree angle in a female, wonderful sharp tip. Sometimes this girl thinks that her nose sticks out too much off of the face and she wants a smaller Q-tip nose. So we have to do lateral crural sliding technique in such cases. So you have to split the lateral crust, separate it from the underlying skin. And then you have to cut it and resuture it. And by doing this, we shorten the lateral crust on both the sides. And by doing this, we can get a smaller tip. We can decrease the projection of the tip. So we could decrease her projection to some extent. Sometimes you have a very over projected tip and very, very large nostrils. So in this case, we had a very huge cartilages we opened up, and it landed up into a Pinocchio nose deformity. So again, here we did a lateral crural sliding technique, and we could get a smaller nose as compared to a very largely projected nose. Sometimes you have various other types of deformities, like a bossa formation over here, which was congenital deformity. Again, here on only one side, we did the lateral crural sliding technique, and we could get rid of this bossa formation. And we also augmented the radix area, and we could get a straight dorsal and also a good breathing nose. Again, as you can see here, you can see this video. So on inspiration, the patient is having a collapse of the lateral wall. So this is because of the weakness of the lateral crus at the lateral wall. So you can strengthen it by strengthening the lateral crus. So this is called as a lateral crural strut graft. So this is how you make a lateral crural strut graft. And as you can see here, the pinching is gone on the left hand side. And he can breathe normally. Even on deep inspiration, there is no collapse. Similarly, you can see here, even on normal inspiration, this gentleman had a breathing difficulty because there was a collapse of the lateral nasal wall, and he used to use such a device while sleeping. So this was because of the malorientation or malrotation of the lateral crus. So we took out the lateral crus and repositioned it in the right position, also strengthened it. So as you can see here, this is the pre-op video, and this is the post-op video. Sometimes you get a Pinocchio nose like this, a very, very long nose. And you have to, as you can see here, we have reduced about 2 centimeters of his nose on the front view, and a very, very, very large nose, very, very hypertrophic nasal spine and the depressor septi muscle. So we could treat that, and we could still get a good result. And the breathing difficulty is also gone. Aging and rhinoplasty. Sometimes in these kind of deformities, they generally don't present in the early age, but when the tissues become lax as the patient grows older, this kind of deformity, it causes a collapse of the airway because of the Bernoulli's phenomenon, and then they have a difficulty breathing in old age, and that can lead to sleep apnea and all. So we did resect this part and replace this part with another cartilage. As you can see here, this deformity is also gone, and he could breathe very nicely. Upturned noses or pug nose deformity. So in such noses, you can see the nostrils on the frontal view. So this is called as a pug nose deformity. This gentleman did not have any breathing difficulty, but these to derotate it, this is a rather difficult job. So in such cases, you have to use extended spreadografts. So we used extended spreadograft and septal extension graft in this case. And by doing so, we could nicely derotate his nose downwards and then advance the tip assembly on the top of this cartilages. As you can see here, we could he got a good, nice looking nose even without any graft material or without any augmentation. All of it comes from the posterior part of the septum, which is present in everybody's nose. So with this, I thank you all for a very patient listening, and I thank the organizers and the team IMA and Dr. Vikram for considering me for this talk. Thank you very much.
Thank you so much, Dr. Kshitij. It was a superb talk. It was really so nice. You told us about the recent advances and the various techniques of rhinoplasty. And now we have a hope that our nose also will be a beautiful one. We come to you,
Sure.
right? Okay. And then we move on to our next speaker, who is another versatile personality. He's done his PG diploma in pathology and bacteriology. He's done LLB. He's done MA in journalism and mass communication, MBA in general management, BA in English literature. And not only that, he holds very important posts in medical and medico-legal fields. He's the member of the steering committee World Medical Association, is the director of IMA Hospital Board of India headquarters, and he's the master trainer for NABH pre-accreditation entry level. And what more than he's the vice president of IMA Maharashtra and the president-elect of IMA Amravati. So in short, I can say he's the face of IMA Amravati and he represents us at national and international levels. So we are really proud of you, Dinesh sir, and over to you for your talk on death certificate in OPD setup. Thank you,
madam. Thank you, madam, for the nice introduction. I will start with the talk. I hope that I am audible and visible both. Please confirm.
Yes, sir. Your audio and video is clear, sir.
Thank you. So I represent IMA Headquarters Standing Committee for Medical Legal Cell, and we have some objectives. The objectives are to impart basic medical legal knowledge to IMA members, to train IMA members to be ethically and legally correct in daily practice. And third one is to boost confidence in IMA members to face any sort of medical legal situation in routine practice. And we have a slogan. The slogan says, be informed, be empowered, be vigilant. This is our logo. And our today's topic is death certificate in OPD setup. So what do we issue? A death certificate? No. We issue medical certificate of cause of death. That is MCCD. So from now onwards, we'll not call it a DC, but we'll call it a MCCD. That is medical certificate of cause of death. And the next question is, who issues the death certificate, the so-called death certificate? Municipal authority. Because in routine talking, we see the doctor has issued DC, or I want to take DC from doctor, the doctor not issuing DC. Actually, DC is issued by the municipal authority. Issuing a medical certificate of cause of death is a duty of doctor, and definitely it does have some medical legal implications. Before issuing the MCCD, the certificate, the doctor must verify and ascertain the name, age, sex, religion, and address of the deceased. That is the expected basic things. Most useful and widely available identity card is Aadhaar card, or you can use any other authentic government identity card that is given. It is not routine practice on our side to demand Aadhaar card or some authentic government identity card in our area, but we should start it as soon as possible. And we should start writing name as same as it is on some authentic government identity card. As you know, the correct death certificate is required for death claim, reimbursement of hospital bills, insurance claims, obtaining probate or succession certificate, then settlement of property claims, release of gratuity, provident fund claims, then family pension, distribution of movable, immovable property, personal accident benefit policy, deletion of the deceased person's name from ration card or movable or immovable property extract, for example, shares, house, flat, farm, etc. What if you give the certificate with a mistake? Maybe yours or anyone's in your hospital in the spelling of the deceased, or the deceased name is slightly different on one document, say for example on one of the insurance company, and you have written some different name, the change in spelling or alteration in spelling. Now after a few days, the relatives come to you and want you to correct the name with the municipal authority, or they want you to issue a new certificate with the corrected name. What will you do? Never give. Offer help in providing documents what are needed, and the attender will have to do the related documentation and office work for the name change or correction. You have to just provide him documents what are needed. If the mistake was on patient side, then most of the time it is okay. But if you had done the spelling mistake, you have to counsel the patient regarding the mistake, and the relatives will have, because otherwise the relatives have reason to be unhappy with you. So you have to be careful. And remember that the certificate is an important legal document from the point of view of the deceased person or the next of kin. This document must be correctly filled in. That is expected from the doctor. The routine guidelines that are given are: you should write legibly in capital letters as possible. You should avoid abbreviations, and you should put initials at alterations or mistakes if you do any. Keep your record that document was keep in your record that document which was given to you to write the name from. That is the government identity cards. So the xerox of the government identity cards must be with you, with the records of the patient for lifelong. Again, never charge a fee for issuance of the certificate. It is according to regulation. You should not charge any fee. Do not withhold a certificate even if dues are still to be cleared by the relatives. This has happened many times, and this has caused disreputation to the doctor and the fraternity also, because legally you are not allowed to withhold MCCD because the dues are still to be cleared. Only a single copy of the certificate should be issued. The doctor should always maintain a carbon copy of the certificate issued. If necessary, only a duplicate true copy should be issued, not the original. You should not prepare a new certificate and issue. You have to issue only a duplicate true copy. Upper part of the certificate is for the local authority, and the lower detachable part is for the relative to get the death pass. And same is for the non-institutional deaths. There are two types of deaths: institutional and non-institutional. This procedure is same for both types of death. Death, even that of foreign nationals, it should be reported within 21 days under the Registration of Birth and Death Act of 1969. Actually, in some cities, they say it is 72 hours. In some cities, there is a practice that on 5th day of every month, you have to submit all details regarding deaths. As of now, I will say that you should follow as per the local orders. Then if there is a delay, if delay is more than 21 days, but it is before 30 days, the late fee is ₹2 according to the Act. And after 30 days and within a year, late fee is ₹5. But there is an addition. You have to have a written permission of the block development officer in case of rural area, and executive health officer or chief officer or executive officer for concerned urban area, plus an affidavit at a notary. So whenever 30 days have gone and you have not somehow submitted the MCCD, you should follow this procedure. Then after 1 year, there is a late fee, plus in addition, there should be order by the first class magistrate or the precedence magistrate only, and no other, because at some places they are taking permission or order from the executive magistrate of the area. That is not allowed. It is somehow still going on at some places. Now, next question is, who will take the certificate from the doctor and submit it to the municipal authority? Most of the time, answer is relatives, but it's not true. Then whose duty is it? It is the medical practitioner's responsibility to forward the MCCD to the registering authority, and it should not be sent through any relative of the deceased. But it is happening, and you can be penalized for that. Cause of death mentioned in the register shall not be disclosed to anybody, may it be relative. And when you give total MCCD to the relative to submit to the municipality, then he knows the cause of death, and there is a penalty for it. And there is section 17(1), which speaks about the penalty. So wrong is wrong even if everyone is doing it, and right is right even if no one is doing it, because most of the time excuses are given like that everybody is doing it, all the other doctors are doing the same thing. But ignorance of law is no excuse, and though they are doing it, it doesn't mean that it is right. You should do the right things. So we'll go for the penalties. What are the penalties of different amounts for the violating or refusing and neglecting the provisions of this act? I know 99% of the doctors are not aware of such penalties. For any person, the penalties are for any person, and the penalties are for registrar also and doctors also. Both the persons, the registering authority and the reporting authority, both may have to pay the penalty. Then next question is, who will have to pay the late fees or the penalty for not following the legal provisions? What do you think? Is it a doctor or a hospital? It is a doctor in charge and not the institution. Because doctor, he was duty bound. It is said by the courts that he was duty bound. Therefore, penalty will be paid by the doctor in charge. So if you are MO in some hospital or in your even in your hospital, you will be personally responsible for not reporting the things under this act. If an authorized department or institution wants the cause of death, then what to do? Like situations like accident cases or for insurance claims, it is the duty of registrar. The registrar will provide it by official communication. There is no role of doctor in this. Then only initial MCCD, the detached lowest part in which there is no mention of medical cause of death, is sufficient to receive a permit. That is the death pass. Death pass is given by the local ward office in the name of the cremation center to dispose of the body. And to my surprise, this procedure is not followed in many cities. The procedure is given in the law, given in the act, but it is still not followed. But whenever there is a problem, the penalty will be given to the doctor, the poor guy. So that we are talking about the permit for which you have to give the lower part of the MCCD, and the relative will go to the local wards, and the ward office will issue the permit in the name of the cremation center to dispose of the dead body, so that the cremation or burial and final rites of the deceased person can take place as per his or her religion. And the next important thing is that it should happen without loss of time or any inconvenience to the relatives and friends. This is also our duty to see that this happens in this way. Now, the certificate should be issued by a medical practitioner. The act says medical practitioner. There is no qualification mentioned there. Now, there is a problem because the qualification is not mentioned. That I will come sometime later. Now, it should be issued by the medical practitioner who has been a medical attendant of the deceased during last illness and examined him while being alive. That is the first condition, or if you want to issue the medical certificate. Second condition, that you should be satisfied as to the cause of death. And third is, you should have attended the patient within the past 14 days prior to his death. Again, these 14 days are not mentioned in the act, but it is somewhat norm that is there. At least it says that at least within 15 days you must 14 days you must have seen the patient. Otherwise, how you can say what is cause of death? Next is that the cause of death is to be based only on the clinical findings and not on extraneous factors. The certificate is to be issued only when the treating doctor is fully satisfied as to the clinical diagnosis and corroborative diagnostic test. Now this happens, doctors give the diagnosis depending on the clinical diagnosis, give the certificate depending on the clinical diagnosis only. But corroborative diagnostic tests are equally important, because if the case goes to the court or something happens, then some diagnostics, some result, test results should be in favor of your clinical diagnosis. For example, ECG in acute myocardial infarction, CSF examination in meningitis. So corroborative evidence is important. Not that you are feeling that this is the reason and this is the cause of death, and then you have given the certificate. A doctor may declare a death, but the certificate is to be issued only on verification and after satisfying all facts of the cause, causing and resulting in the death. This thing has to be kept in the mind. And once you are sure about the cause of death, there is no doubt, then please do not delay the issuance of the MCCD. If you attended a patient in the last 14 days, I told that it is just norm. If you attended a patient in the last 14 days and the patient has died at home, relatives want you to visit home to issue the certificate. What will you do? It is your duty. It is your legal duty to visit. You can't say no. If you are confident that the death has occurred because of the underlying condition for which the patient was under your treatment, issue the certificate in the 4A format, that is non-institutional death. There are four formats, 4 and 4A. 4A is for non-institutional death. So please issue the MCCT. On home visit, this is important, look for signs of any foul play or unnatural death. If you suspect some foul play, the best advice is to take the patient to some nearby hospital along with the medical records. This is the way out. There are problems in the way out also, we'll discuss later. In case, because of highly genuine reason, you can't visit, or you can give this reason also when you have suspicion in mind. You can tell this reason. Request relatives to take the patient to the nearest hospital with all medical records if you have suspicion. So, if you have some suspicion and you have highly genuine reason, don't release the certificate. Ask the relatives to take the patient to the nearby hospital. The MCCD has to be sent to that registrar within whose jurisdiction area the death has occurred. It is important for the doctors having clinics or working in hospitals at two places in the areas falling in different jurisdictions. The jurisdiction area means where the death has occurred, not where your clinic is. So this may happen in practically, especially when the doctors are having hospitals at two places in different areas of what? Of whom? Of different areas of registrar. Or you are visiting a home for declaring a death, giving a certificate. Then please see that who is the registrar of this area and report there, not at the area, not at the registrar of your area, where your hospital is there. One important case scenario, if a serious patient comes to you, to your OPD, and you examine him, you give him treatment, and then shift him to a higher center, and he dies before reaching the higher center. This condition happen most of the time, and then the relatives want to come back to you. What will you do? You can give the certificate because you have seen the patient just some time back and you know the cause of death. But again, the things can happen. In the midway, the relatives may do something with the patient. So you have to keep watch. If the patient is unknown and their body language is suspicious, and if you are suspicious that the relatives may do something wrong on the way, best way is you or your assistant, as per the need, should accompany such serious patient with whatever instruments and facilities either you have or the ambulance have. Whatever you can provide during such transportation, with it you or your assistant should accompany. And in otherwise case also, I think that this can be you can make this a routine practice, because otherwise also this is a safe practice. On the similar principle, you shall not issue the certificate for broad dead patient. This is the very common question. That patient, they have brought the patient to us, and patient was brought dead. What should we do? Simple answer is you must not issue the MCCD. A doctor who had last seen the patient can give the MCCD. They may say that nobody has seen before, nobody has seen 14 days, within 14 days, then inform the police. Otherwise also inform the police, because police has a choice. Police has a power to either go for PM or waive it. It is their power. You should not fall prey to the relatives' request. Right. So inform police even if the relatives take away the body, because sometimes if you say that we will not give, give the certificate and you will inform the police, what the relatives do, they take away the body. Even if in such case you have to inform the police. Such and such patient came to you and he was brought dead, and the relatives took away the body on their own, or even if you requested them to stop, they did not stop and they took the body forcefully. So this is important. Most of the time we do not inform the police to avoid the problems, and sometimes the politicians comes with the body, brought dead body, and they force us that you should give the death certificate like that, and then definitely it is your choice if you want to risk your practice and you have to succumb to the pressure by the politician. That is your choice. In such cases, you can call IMA. I am president, secretary, or I am a person you can call, and such thing has happened. And when 4 or 5 people come together, then they will definitely not force you for to do the illegal things. Sometimes someone may attempt to refer brought dead patient so as to avoid the crowd or legal jargon. You know the patient is brought dead, but still you want to refer because you want to avoid the crowd or legal jargon, and you just put some notes and refer the dead body, but then you become the doctor who had last examined, because whenever the MCCD has to be delivered, has to be issued, it has to be issued by the doctor who had last examined, and you had examined a dead body and you have referred the patient, refer the dead body. Now what the next hospital will do, they will inform police that we have received a dead body. And then who has seen the patient last? You, just 5 minutes back or 10 minutes back. So it is more problematic. And because you are the doctor who had last examined, you have no option but to issue, because you have put some notes, you have referring note, etc. Then it is more complicated. So don't be afraid and just declare that the patient is dead and inform police. It is better than facing legal consequences on later date. Some take-home messages are there. If there is a dilemma, shall I issue the certificate or not? The dilemma is, shall I issue the death certificate or MCCD or not? Then go by these 4 points. First point is, are you damn sure that you know the cause of death? Answer is yes, you can give. Right? Are you damn sure that you know the cause of death? You can give. But do you have sufficient corroborative evidence? Yes, then definitely you can. You should not stop yourself and you should give the MCCD. No issue. Then to be more precautious or to be more safe, can you convince another medical expert that why it is the cause of death? If you answer, then you have the answer for this, then no issue. And it is foolproof if you can answer the 4th question. That question is, can you prove to a legal expert that you know the cause of death? If you can answer 4th question, nobody in the world can sue you in the court. Or if you sue in the court, you will be relieved by the court, definitely. And to prove that you know the cause of death, if you are dealing with the medical expert, you have to discuss, but you will have to argue with the legal expert, though the issue is same. In the following cases, if you know the cause of death, you can declare the death to the relatives, but still need to inform the police. You know the cause of death, and you can declare death to the relatives, but still you need to inform the police and issue and hand over the certificate to the police, not the relatives. You know the cause of death, you have declared the death, still you have to inform the police and give the MCCD to the police, not the relatives. What are those conditions? First, married ladies dying within 7 years of marriage, unnatural death, medical legal case. In these 3 issues, you have to inform the police and give the MCCD to the police. Again, you know the cause of death occurred at your place. Next scenario, but suspicion about relatives' intentions. Then again, involve the police and obtain a no objection certificate from police. Police have the right to waive off the PM that I told you, so that after a few days, relatives will not change their mind and sue. Always keep the possibility of suspended animation in mind. If you have any sort of suspicion, wait for some time. You must verify all the relevant facts before issuing a MCCD and should not issue MCCD under any pressure. If the dead person is not your patient, it is not mandatory to visit the home to confirm the death. And in case if you visit out of courtesy or because that person's home is near to your clinic or any other reason, just give a declaration of death certificate on your letterhead. No MCCD. Do not write probable cause of death anywhere, not even in some corner, as he was not your patient and you don't know the cause of death. Even if the relatives are ready to give a statement in writing with clear mention of morbid conditions, signs, symptoms, duration, and all sorts of commitments, never, never, never give the MCCD. Postmortem must be recommended only when the cause of death is not known. And when you know the cause of death, postmortem is not necessary. Be clear. In case of suspicion of death due to unnatural cause, you should only declare death and not the cause of death, and must inform police for further investigation and postmortem. And in some cases, even if you are sure about the cause of death, but somehow the patient's attendants insist or request for postmortem, you should go for it. Don't show your knowledge there. Just go for the PM, because the patient's relatives are demanding. MCCD should not be issued in case of sudden death of a person who has not been examined by you before his or her death. Now this thing must be clear by now to you. Declare the date and inform the police. Permission from the dead patient attendant is not at all necessary to send the body for a postmortem. Never issue a MCCD without viewing and examining the dead body personally. It should not be signed blank, leaving the details to be filled by someone else, for example, assistant doctor, because it is a medico-legal document. In a partnership practice, one doctor should not certify the cause of death of his colleague's patients. It happens, no? Your colleague has gone out for some 15 days or 1 month and his patient dies. And they say that he is the patient of your colleague. In such cases also, because you have not seen us, he's seen him or her, you have not seen him within the last 14 days, so you should not give the MCCD. Do not issue the MCCD, do not hand over the body to the relatives and inform the police if. Do not issue the MCCD, do not hand over the body to the relatives and inform the police if. First case scenario is the injured was brought dead. Second, the crime has already been registered by police and you know it. The police has already been informed about the case. There are such scenarios we can discuss not now. Or when the cause of death is not known. So A and B you can easily relate, I think, and B and C we need some more discussion. Never give MCCD and must inform police when brought dead young male, brought dead young female, brought dead child, homicide, suicide, unexplained unknown death, suspected unnatural death, unexplained injuries, poisoning, accidents, suspected criminal taking shelter near hospital, food poisoning, absconding patient, relatives of dead patient forcibly taking away records. Just inform the police. Absconding patient means the patient who was absconding and now dead. Suspected criminal means the suspected criminal taking shelter in hospital and now dead. Got it? And just inform the police and they have power to have the postmortem. How to inform? Then best is to inform control room 100 or 101. If you inform to a police station on phone, note down inward number or buckle number. Note it on case paper with date and time. Don't shift the body while informing the death. That is important. The hospital authorities or physicians should inform the registrar concerned detail thereof for follow-up action in obtaining required certificate from the police authorities. The object is that on receipt of the information, though the local registrar could register the event of the death without completing the column of the cause of death and making a remark in the remarks column that inquest report is awaited. Let him do his job perfectly. The cause of death could be filled in later or on receiving the inquest report. That is his job. In a medical legal cell, confidential information, any documents, and any clarifications regarding any medical points should be given in writing as per IPC 179 or CRPC 161. And importantly, proper receipt shall be obtained for all such handovers. Just do not hand over the material or any documents or any forensic material of forensic importance. Other, in case any material you are handing over to any police, proper receipt shall be obtained. Oral statements made to the police and recorded by the police should not be signed. It is not at all necessary to sign the oral statements you make to the police. Now these are the forms. Form 2 is about death reporting by other than medical personnel. Form 3 for stillbirth reporting. Form 4 is for MCCD for institutional death. Form 4A is for MCCD for non-institutional death. Form C is death certificate. Now this is the form. Most of you have seen this form, and it is self-explanatory. You have to just go on writing what they ask. Most of the, I may say that all of the doctors have seen this form, and all the hospitals are having these forms. We'll discuss a little bit about the what is there in the forms. Now the important thing is the MCCD recommended by the World Health Organization for international use is in two parts that everybody knows. Part 1 is it records A, the disease or condition directly leading to death. The symptomatology or mode of death, for example, cardiorespiratory failure, asthenia or asphyxia, etc., should not be recorded in the cause of death unless explained. Remember all the time that this is a cause of death certificate and it is not a mode of death certificate. And I can tell you that nearly 30-40% in 30-40% certificates today also the mode of death is written, not cause of death. And this is the apathy.
Dinesh sir, your slide is not moving.
Slide is not moving.
Yes, I think we are stuck at key factor knowing cause of death.
No, sir, it is working fine, sir.
So problem is at Vikram's side.
Yes, sir. The things are working fine from the Dinesh sir side.
Okay, fine.
Okay. So I was telling about 30-40% certificates still today. They write mode of death as the cause of death, and that is the problem. B is antecedent causes, that is morbid conditions, if any, giving rise to the cause which I have mentioned in A. Thus, to be simple, A must be due to B, and that many doctors know. The underlying cause of death is defined as the disease which initiated the train of morbid events leading directly to death. The basic pathological condition is that which is mentioned on the lowermost line, and this is the one that is used for statistical and epidemiological purposes. Actually, this presentation was prepared for general practitioner, therefore some basic things are there. In part 2, it records the other significant conditions contributing to death, but not related to disease or conditions causing it. And interval you have to write approximately between the onset and death. That is also there. And the International Classification Diseases, the ICD, should be used in MCCD whenever possible to maintain uniformity and facilitate fast retrieval of data. This is expected, and computerization is being done, but there is no mention of qualification of medical practitioner in the Act. So when MBS doctor find it difficult to understand the International Classification Diseases and write it, how the doctors with other qualification will do it? That is a major issue. Now we'll go through some examples, like part 1 in A. It is if it is a peritonitis or acute, then B should be the perforation of small intestine 12 days, strangulated femoral hernia 15 days, and there is nothing in part 2. For example, if part 1A, it is a pulmonary embolism 1 hour, then acute myocardial infarction 7 days, chronic ischemic heart disease 8 years. Part 2, like non-insulin dependent diabetes, mellitus, obesity, hypertension, congestive heart failure, like that. Third example is if it is acute exacerbation of obstructive airway diseases, time approximately 12 hours. In B, you can write chronic bronchitis, 10 years. You can leave the C blank, and in part 2, you can write cigarette smoking. In the fourth example, in 1A, if you write acute renal failure 1 week, there is a reason, nephropathy 4 years, and diabetes mellitus 12 years. And in part 2, chronic ischemic heart disease 5 years. These are just examples. In part 1A, it is DIC since 1 hour. Then it is B, it is hemorrhage in 13 hours. And it is because of abruption placenta over 13 hours. And part 2, you can write gestational hypertension. Likewise, septicemia, gangrene foot, diabetes mellitus, fracture of aorta, skull, fall from tree, crush, chest, automobile accident, etc. Now this is important. In old age days, if there is no disease and if there is no specific cause of death, what will you write? Cardiorespiratory arrest? That is the thing we do. You can write a senility because there is naturally no specific cause of death. And this is again a somewhat debatable issue that some people still feel that you should not use the senility word. But again, cardiorespiratory arrest is the wrong word, wrong cause of death. If you have some cause, then write senility in the contributory factor. Say, for example, you can write chronic bronchitis 5 years, and part 2 you can write senility or this. Manner of death, natural accident, suicide, homicide, pending investigation. You have to mark in the MCCD. And then how did the injury occur? If disease was a female, was the death associated with the pregnancy? Yes or no? If yes, was there a delivery? Yes or no? Doctors should necessarily use their rubber stamp after affixing a signature to the MCCD. At the lower part of the certificate, the qualifications mentioned should be those registered by your state medical council and not others. Be confined to the qualifying degrees and not to the variety of postgraduate diplomas. Printed forms are made available by the municipal authorities to doctors and hospitals for issuing MCCDs. If a doctor does not inform the police and gives the certificate by filling the wrong cause of death, and someone takes objection later on, then what will happen? The doctor may be held liable for destruction of evidence, tampering with evidence, conspiracy, etc., depending on the allegations in the particular case. So never give wrong cause of death. If you don't know, just inform the police, and if you do this, you alone are responsible for your fate. Now, there are some references. These are references. Among this is the third one is much important. If anyone wants to go in detail, then this MCCD training module by Office of the Deputy Director of Health Services, Pune, is a very good book. And next one is Physician's Manual on Medical Certification of Cause of Death, MHA, GOI, 5th edition. These two books are very good books. These are other references I referred to. There are some websites, and I must thank Dr. T.N. Ravisankar, Chairman of our Medical Cell, Dr. Jayant Daurangi from Pune, and Dr. Pawan Kumar Patil from Bangalore, all our medical teammates, and very important inputs from Dr. Dinesh Magade, Amravati. So at the end, I will say that everything in the medical field in practice, it is a journey of self-regulation, and together we can do it. And not only doctors, but lawyers, managers, reporters, and governments and police, they all should go towards self-regulation, not only advising doctors and do this, do that. Everybody is the part of society, and everybody should follow the self-regulation if they want to teach or tell others, other sections of the society. Thank you very much.
Thank you so much, Dinesh sir. It was a great talk. It was definitely an eye-opener for many of us. This was a very serious topic and an important topic for doctors of all specialities. And you have really made our ideas clear regarding this topic. Thank you so much, Dinesh sir.
Thank you.
And this was the last talk in this webcon. I thank our ADC, Dr. Vikram Deshmukh sir, and our President, Dr. Rohankar sir, for giving me this wonderful opportunity to conduct this webcon. And of course, I thank all the speakers for their excellent presentations. And I thank all the delegates and all our viewers for their valuable presence and a very patient listening. Hope it was an academic treat for all of us. I think I should hand over to our ADC, Dr. Vikram Deshmukh. Thank you so much. And yes, last but not the least, I want to thank Mr. Pratik Agrawal for handling the technical side so well. Thank you so much, Pratik sir. Over to you, Dr. Vikram sir.
Yes, thank you, madam. Okay, Pratik, is my video on?
Yes, sir, your audio and video is clear, sir.
Okay, we had a great session today. On behalf of IMA Amravati, I take this opportunity to thank those who have directly or indirectly contributed to this web conference. At the outset, I want to thank IMA Maharashtra State Vice President Dr. Dinesh Thakre sir for motivating us and giving us his valuable guidance from time to time. I thank President IMA Amravati Dr. Anil Rohankar sir for his unflinching support in all the activities that we have planned for this annual conference. I want to thank Secretary IMA Amravati Dr. Dinesh Sabu sir, executive members of IMA Amravati, Secretary of AGNIPANKH 2020 Dr. Pallavi Murkey, and other members of Team AGNIPANKH 2020 for their help in organizing this event. I thank all the speakers who have enlightened us with their knowledge in these 2 days. Our heartfelt thanks to all the delegates who have participated in large numbers. I also thank our moderators, Dr. Vikram Wankhede and Dr. Anuradha Tote, madam, for conducting the web conference meticulously. I thank Mr. Pratik Agrawal, who has given us technical support for conducting this conference. At the end, I thank IMA Amravati for giving me this opportunity and responsibility of organizing this year's annual conference. I want to remind all speakers and delegates that MMC has granted credit points to this conference, and you have to fill the Google form to mark your attendance for this conference. You can find the link of this form below the screen on YouTube. With the permission of our President, Dr. Anil Rohankar sir, I declare that this conference is over. Thank you very much.